racial disparities when it comes to health outcomes. So one of the important intersections here, however, is mental health, particularly in communities of color. Many of you may know that the challenges of access to mental health care services have been, I can't even find the right descriptor to talk about how absent they've been from our communities due to a disinvestment over a generation from our state infrastructure. Governor Gretchen Whitmer and I are committed to rebuilding that infrastructure because our communities need it. Mental health is a part of overall health and well-being, and we need to invest in that. When it comes to communities of color, we understand that there are specific mental health challenges that arise due to the pressures and circumstances that are presented by whether it's racism and prejudice, whether it's being systemically excluded from opportunity, community disinvestment. It has led to outcomes on the mental health side that have then made other challenges become present, whether that's increased interactions with law enforcement, lower outcomes when it comes to education and jobs, et cetera. All these things are part of our community's well-being. We are working to invest in making sure that those services are more present during the pandemic. And hopefully, if people are able to get connected to the care in the context of COVID-19, we can then connect them to that care over the long term. We've done a pilot doing this with primary care physicians and primary care healthcare services, and we're looking to extend that to mental health services as well. The stresses, the emotional burden and emotional labor that's been put onto people and communities across the state with this pandemic is something that is unprecedented. No one alive really has lived through anything like this. And it impacts people of all ages, whether it's adults who are those who are working on the front lines and were not ever ones who stopped working because their jobs were critical to protecting and sustaining life. They've been going to work worried about getting sick. Where there's people who've been able to work from home, but they've had the responsibility of also trying to be education professionals to make sure their children learned. That's stressful while you're trying to do your real full-time job. And even children themselves, especially kids, asking some big questions that they've never been confronted with, being worried about being able to see family members or experience holidays. I mean, on a personal note, I have twin 6-year-olds and a 1-year-old, and my older children had a lot of questions about the baby's birthday and what's going to happen with Christmas, and we can see our grandparents. So these are real things that are mental stressors that are impacting children as well as adults. But we do have an opportunity to address these challenges in real time and invest in solutions for the long term. And I'm thankful for everyone who's participating in this event to not only raise awareness about the specific and unique and acute challenges that must be addressed, but also to brainstorm and strategize about what the solutions are to these challenges. Know that the state of Michigan, our administration, is going to be right there as a partner, and know that we're going to need your help to work through the legislative process to make sure that we can budget and appropriate funds to invest in this kind of infrastructure, because it is critical to our overall public health and community well-being. And I know and I believe that when we invest in communities of color's mental health and well-being, that will indeed increase the resilience and the sustainability of our mental health for the state, across the state, in every community. We all benefit when we all benefit, to put it simply. So you have an ally here in my office, an ally in our administration, and we're going to work hard every day to make sure people have what they need to be healthy and to be successful. So thank you for all the work that you're doing. I encourage you to be bold and imaginative, and we're going to be right there with you.
Thank you so much, Lieutenant Governor. We really appreciate you being here today and working through all of the technical challenges through these new virtual forums that we're going through. We'd like to pause for just a few minutes and take some questions now. So again, just to remind everyone, you can put your questions in the chat box. You can use the raise your hand function, or if you've called in, please feel free to hit *6 to unmute yourself. And if you have questions for the Lieutenant Governor and you're more comfortable texting those, please text them to 248-330-1175. So we're going to pause just for a moment and see if we have any questions. Oh, I saw a hand raised for a moment and it went back down. So Lieutenant Governor, the question for you is telehealth something that will be used in the near future, especially with COVID? Oh, I'm not sure. I see he's on but muted. So while we wait to try and get the Lieutenant Governor back, I can say that from the perspective of Oakland Community Health Network, our supports at the state at MDHHS and the state level acted very quickly to ensure that telehealth was available to be provided for as many people as possible. There has been a lot of advocacy that that be allowed to continue. And we have heard very, very positive feedback and received a ton of great support from the folks that we work with at the state level as well to continue telehealth as an option for folks.
Hi, I'm unmuted, but I'm honestly I'm unable to hear any questions or anything. So I can't hear folks if they're speaking. I'm sorry.
Oh, okay. I'm sorry. Can you see the chat?
Yeah, I'm looking at the chat now. So all right, I'll do the best I can on this, y'all. So I see a question about telehealth. Yes, we are investing in telehealth services. As you know, there is certainly stratification in terms of internet access when it comes to communities of color across the state. And this is something I've been focused on pretty intently since the beginning of the pandemic, mostly from the perspective of education. We have 600,000 children in the state who do not have internet-enabled devices in their homes, and about 60,000 kids who don't have access to the internet at all in their homes. So we work to try to close that gap in a pretty significant way. And that opens the door to having more households be able to connect to telehealth services. And I know that telehealth services can be particularly useful in the context of mental health and support services. One of the key investments that we made, thanks to our federal emergency disaster declaration, has been creating a warm line in MDHHS for people to be able to call or text to get connected to crisis counseling services, which has been really critical. And we're looking to see how we can expand and deepen those services as well. Okay, temporary direct wage increases through the September 30th, and that where you're looking at, do we support wage and direct care wages permanently? Absolutely. Yeah, I think that if anything, we knew that that work was important, and we're seeing how much more important it is in the context of a public health emergency. And so we certainly want to look to find ways that people can be, compensated fairly for the work and the risk that they undertake. I see a question about best practice for behavioral health providers specifically. So folks may have seen the action that we took as a state last week, which was by executive directive. Our administration has directed the Department of Licensing and Regulatory Affairs to frankly change the standard for what it means to be a medical professional in the state of Michigan by requiring training on implicit bias. And we're only the second state to enact something like that. California was the first. And the reason that's important is because we want to make sure that people, medical professionals, are recognizing that we all have biases. This is not merely a thing about race. Black folks have biases too. And so we need to make sure, though, that everyone is mindful of how those biases can creep into decision making. In the beginning of this pandemic response, what we saw when we had limited testing capacity because of the failed national strategy, that medical providers were put into an impossible position to have to make a choice about who got a COVID test and who didn't. And oftentimes, implicit bias was present in those choices, because whenever there's a choice point, there's a time for bias to present itself. So we need to work to eradicate that and also make sure people recognize that bias. So I think that I think that for behavioral health providers specifically, one, I think it's being sort of mindful of that. Two is, I think, being just really, I mean, as a behavioral health provider, you're already sort of empathetic by nature and by training, but to really lean into that in terms of the stresses that people are dealing with, and make sure that the questions that you're asking folks are also with an eye toward connecting them to other services that may be necessary for them to be able to not only get through this pandemic, but also to set them up for positive health outcomes overall. I know that folks may not be able to hear me, but I do have to jump for another meeting right now. But I appreciate everyone participating in this call, allow me to participate in this way. And if folks can, please, you can contact my office to send over other questions. I know we didn't get to all of them, and I'll be sure to make sure that we can get y'all answers. So thank y'all for the work. Please take care. Please stay safe.
Thank you. Thank you so much, Lieutenant Governor. And for everyone else, we're going to go ahead and move on. And so I'm going to turn things over to Nida Khan. Nida?
Morning. Can everyone hear me?
Now we can, yes.
Okay, good morning. Good morning, everyone. Alrighty, so my name is Nida Khan. I am a provider network analyst at OCHN, and I have been with OCHN for 5 years now, and I will be introducing our next speakers. So it is my pleasure to introduce Ellen Jensen, Senior Deputy Director of the Michigan Department of Health and Human Services, Behavioral Health and Developmental Disabilities Administration. Ellen has been engaged in Michigan's public health, mental health safety for nearly 4 decades. He began as a case manager in Michigan's first assertive community treatment team. Formerly, he was a chief strategy officer working to improve clinical and policy practices. He also previously served as the interim director of Kalamazoo Psychiatric Hospital. I'd also like to welcome Brant Wimbush of the MDHHS Diversity, Equity, and Inclusion Council, where he co-leads the Service Delivery Action Team with Ellen. They are charged with ensuring all the MDHHS policies, program services, and contracts are diverse, equitable, and inclusive. Now I'd like to welcome Ellen Jensen and Brant Wimbush.
Good morning, everybody.
Good morning.
Good morning. I'm very glad to be here. And I thank you for introducing Brant. So I'm fairly new to the department, and Brant has been very instrumental not only in preparing today's presentation, but also equipping me as the co-chair for the Diversity, Equity, and Inclusion Council. So you may know that is about, I think it's about 3 years old, the council. It has 5 action teams, and Brant and I co-chair the action team that is focused on service delivery. So Brant is going to help me, particularly at the end during the Q&A session, because he carries considerable more of the history of some of the actions within the department. So thank you, Brant, for being with us this morning. I also want to acknowledge 2 other members of the Behavioral Health and Developmental Disabilities Administration that helped with this presentation, and that is Sharita Akins and John Villacerta. So let's move on to the second slide. And thank you. So I want to do a little bit of a synopsis and I think an overview of what I'm hoping to accomplish today. I wanted to make sure that we were all on the same page with the definitions. I do have a number of statistics for Oakland, Michigan, and also the US. I will not spend a lot of time on those stats. I think they're pretty self-explanatory. I'd like to look at some disparities that we do know about, that we have some evidence of, and then I want to focus more on the current strategies and the future strategies. So let's move on to the next slide. When I was preparing for this presentation and ran across this quote, I felt like it set the stage rather perfectly for what I am hoping to leave with you today. So I actually am going to read this. I promise I won't read all of my slides, but I found this to be a very powerful statement for me personally, but I'm hoping it is for you as well. So normal never was. Our pre-corona existence was not normal, other than we normalized greed, inequity, exhaustion, depletion, extraction, disconnection, confusion, rage, hoarding, hate, and lack. We should not return to normal, my friends. We are being given the opportunity to stitch a new garment, one that fits all of humanity and nature. Sonia Renee Taylor. So, of course, it's important to recognize all the problems identified here. I also believe that from an overview standpoint, when you think about stitching a garment, if you're familiar at all with stitching, you know that it takes a lot of hands and a lot of stitches. And I think if nothing else is remembered from this presentation today, the main point is that we are in this together. We need to choose to be in this together, and we are in this, and it will take all of us to make a change in affecting disparities. And so I encourage and challenge all of you to do whatever part you play in that to have an impact. I think let's move on to the next slide. I think I want to say a little about Sonia, just that she is a poet and an author. And for all of you who've been executives, I love her title. She's a radical executive officer of a movement called The Body Is Not an Apology. So I love the title of radical executive officer. So I think tying some things together, the other thing I'm hoping to accomplish today really is depicted in this slide. So of course, equality is important, but it doesn't address the kind of equity that we really need in our environments. Equity is important. Clearly, it's a huge step, and it's an important, maybe even next step in some cases. But it doesn't get at the barrier that's beneath it. We have to address the barrier. And that's what leads to justice when we get rid of those. And I think as we talk about some of the disparities, we're going to realize, I'm sure we already realize, how far we have to go to get to the justice point. Let's move on to the next slide. So the definitions are important. Disparities, I think when we look at disparities, I think especially as we start looking at the data behind those disparities, we need to look at the 3 points here, that there's an effect on health condition, there is an effect on access, and there's an effect on the outcome to treatment. And of course, they're all linked to the social determinants of health. But as you'll see in the data, that we're going to look at a little later on, that you see some interesting patterns begin to emerge around what the data is telling us. And sometimes we will notice that it looks like there's an access problem when actually it may actually be something different than that. And the data itself is a huge and important variable for us to look at. Diversity, of course, range of differences. Equity, I think, we need to look at the access to all opportunities. And I think there needs to be the distribution across everything that we do. And I think, again, I hope that you'll see that in some of the work that we're beginning to do. And then inclusion. I think inclusion has a lot of steps to it. As we've been doing some of our internal work in our department, we realize how far we have to go to affect every facet of the organization. Okay, let's move to the next slide. So here, of course, is just a list of the impact of the social determinants. I don't mean this to be an inclusive list. I think it's a fairly thorough list. I would suggest to everybody this morning that everybody's had some experience of being affected by a social determinant. I am now certainly past the age of 50, and I do remember at the age of 51 the experience of what it was like to be considered old in the healthcare system. And I don't mean to compare that in any way to the level of social determinant impact. I only say that to recognize that if you've had an effect of one, you begin to have a taste of what it must be like to have an effect of many of these. And the barrier of just one is powerful. The barrier of many of these social determinants is profound. And again, I think Lieutenant Governor certainly hit a number of the impacts that the social determinants have on us and our citizens. So let us move on to the next. So there are a series of slides here, and I think this is really just who's in the CMH system, and you'll see that communities of color are overrepresented, or maybe positively are accessing the system, but are overrepresented as a percentage of the population, and that's true whether you look at Oakland County or whether you look at across the state. And again, I'm not going to talk about my interpretations of that at the moment because we have a lot of ground to cover, but we can get at that in some of the Q&A if you'd like. So let's go on to the next slide. I think what you're going to see is that we're going to look at just a few social determinants and how they're impacted or how they're demonstrated in the data. And what overall you're going to see is I think what everybody knows. This is just a depiction of the communities of color are overrepresented in below the poverty, and Oakland, in many of these cases, as a standalone county or a separate county, fares better overall, but still populations of color have increased impact in this social determinant as well. All right, next slide. I think, again, another social determinant is income, and the median income here is, again, demonstrated, I think, very, very similarly. You will see that Oakland, once again, is higher as a medium income, so that's good. On the other hand, you will see in comparison the populations of color other than Asian and Native Hawaiian are in fact below the statewide average. So again, I think nothing here is a surprise. All right, next slide. Another social determinant, bachelor's degrees. And again, it's just one of the markers that are looked at. But there again, I think you'll see that Oakland as a county is faring better than certainly the Michigan and overall in the U.S. in almost every category. But again, other than the Asian alone race, we have a definite, clear demonstration here of the social determinant of health impact of education. All right, next slide. This is a really very interesting, begins to take a little bit of look at the mental health side of the disparities. And John, who put this together for me, highlighted all of the disparity areas, and we could really spend most of our session talking about these items here. I want to just talk about a couple. Well, first of all, this is done every year. This is done by Michigan. It's a phone interview. So it's not scientific in the sense that that there is other than I think about 500 citizens to 1,000 citizens are contacted every year. But I want to take a look at one of the things that the strategies that you'll see later on is that the state of Michigan, through the leadership of Brenda Jegaday, is taking a look at the impact of data and what we are collecting. And so if you look at the depression line, one of the things that you like, how do we interpret that if you've ever been told about depression, that Blacks and Asian Pacific Islanders are below the average? Well, I mean, that one could decide that's a good thing, I suppose. It also might demonstrate that there's an access problem. It might demonstrate that there is a cultural competence assessment problem. We need to know, and it's somewhat tragic that we've been collecting data for this long and we don't know the answer to that, because you can't target your solution when you don't know what the real answer to the question is. And I think if you go to the next line, if you'd ask, have you ever been told about a disability? I'm sorry, let's go back to the last slide. Yeah, the next line, sorry. Yeah, around disability, I think there again, you look at the category, ever told about disability if you're Black or if you're Asian Pacific Islander. There's two, and also American Indian and other are all considerably off of the norm there, or at least the typical. And we don't know the answer to why that is. We can speculate and we might be right, but we need to target our data collection so we know the answer to that, so we can actually address the disparity that is underlying that access problem or that demonstration there. All right, next slide. This is a fundamentally powerful slide in and of itself, and Lieutenant Governor certainly addressed this. This is really the demonstration of the number of deaths in Michigan. I believe this was, I believe it was about 3 months into the review, and you'll see that the chart for Black and African American alone is the only chart going in the wrong direction as a percentage. And again, I know there's no surprises in this, but it's certainly a painful graphic demonstration of the disparity problem. Next slide. And I think this is Oakland County essentially alone along the same review. And I think if you look, I didn't talk about the percentages in the last graph, but the percentages in Oakland County of Black and African American in particular, as a percentage, and then as a percentage of folks who've been infected and deaths, is actually almost identical to the statewide average, within just a few percentage points. So again, what does that mean? I think I think we need to know, and we at this point are probably everybody on the call or on this in this event has an interpretation, but we need to improve our collection so that we know the reason for that. Next slide, please. This is a really interesting, and I put this in because it really puts a lot of things together. It's a little complicated. You have to look at it a few times, but I think the arrows, of course, on the bottom are talking upstream and downstream, and below we're talking about which direction are we headed as a process. If you look at the pictures under the top bar, what we're really seeing there is a collection of social determinants that are then compounded or not compounded by institutional inequities, in most cases compounded, further compounded by the living conditions. Additionally, the risk behaviors add to the to the mortality rate and then disease and injury. So we've certainly moved in the wrong direction there by adding those together, and that's certainly we could really describe that is a lot of what our current system has been, is, and below it though is pictures, I would say, of how we can begin to address that. So at the bottom in the orange box is we need policies, and that's where Brant and I certainly come in, and other leaders come in to affect policies. And you'll hear if Brant talks about the passion for policy development that is in our committee. It's not enough though. We need the community engagement, and I think that if a lot of times we've not done deep community engagement, and you will see in one of our strategies that that's a change that we're making. We also need advocacy, and that's where certainly all of us come in. And then on the far right in the bubbles is really 3 different versions or statements of different kinds of treatment. So we need all of those to be culturally sensitive, of course. And then we can move to the new emerging model for public health, which addresses the inequities at its core. So again, I really like this. I think it pulls a lot of things together and wanted to share it with you. Let's move on to the next slide. So while we all have perceptions about what's going on in the mental health arena, I will tell you that there, of course, is only speculation at this point. The strongest evidence I could find about what impact we're having on mental health is a few anecdotes that I'll add as we go through this, and some of the things we're discovering in our hotlines and warm lines. But the other thing is a Kaiser brief, which is a Kaiser Permanente Foundation. So this too is simply a phone call review of hundreds of folks across the United States. But again, they're hints of what we need to look at deeper, but they don't tell us anything too absolute yet. What is not a surprise is that if you shelter in place versus not sheltering in place, and of course there were some states that had different interpretations about sheltering, that there's roughly a 10% negative impact if you are isolated. I think not a major surprise there. We know that the poor mental health is associated with so poor mental health increases with the reduction in income. So again, strong evidence, or at least some evidence, of a social determinant of health. We are starting to see some increase in mental health and substance use. Even in our own evidence, it's not very strong yet, which is why I didn't include it. I just wanted to let you know that we're beginning to see that there's an increase in some substance use deaths that are occurring in some of the reports that are now coming in from February and March. And we're also seeing in our hotlines and warm lines and in our crisis text line that the usage patterns remain fairly high. And so we're hoping that those take the sting out of some of the early isolation issues, but I think we don't know that yet. We do know that the suicide risk is associated with isolation. And again, we're just beginning to see some of that mostly on the side of substance use disorders. I think many of you know this already, but the 1 in 5 suicides, and this is before COVID, are age 65 and over. So one of the things that Lieutenant Governor talked about was that we were a state that is a disaster area. So we were eligible then to apply for a crisis grant, a crisis counseling grant. So we chose, based on some evidence nationally, what the 5 target areas were to invest our early response. One of those, in some cases it was a location. We chose Detroit in the Wayne area as a location. In some cases it was population, and one was elderly. Again, primarily because of the impact of isolation. I apologize, I've forgotten the ratio of unemployment to suicide rates, but it's staggering, and it's a direct link, and that was borne out in 2008 when a water review of unemployment was done. The next point, the pandemic. There's a lot of cracks in the system. Certainly, we've seen access issues. We have seen on the children's system that there is a decrease in the unification in families. We've seen some patterns of abuse go up, and how do we, well, here's how we know that. In some of our warm lines and text lines, we actually track by word the actual numbers of words that are used by callers. And we're starting to get younger callers, and we're starting to get individuals who are talking about abuse and neglect. So again, that's based on a national database as well, but we're seeing an increase in Michigan. We're also seeing, we experienced pretty directly on the testing that we found a number of biases in doing the testing, and I can again talk more about that if you'd like when we get to the Q&A. Let's move on to some of the strategies. All right, I may have said this enough already, but the data collection, if you look at Brenda's work, and I have summarized like 6 pages of Brenda's work at the department into one line, saying that we need to collect information better by race, by other groups that are experiencing a disparity. But it's more than that. If you've ever done a quality improvement cycle, you know that you have to communicate it, you have to evaluate it, and you have to alter it so that you find out the root cause of whatever you're after. And we have not done a good job of that. And that is one of my commitments as the senior deputy for this department. We need to use additional methods to communicate. I think it's tied. I'm just going to also talk about the class at this time. The class, the culturally and linguistic appropriate services is what the S stands for, has 15 standards. One of those is communicating with the groups that have a disparity. And I worked using the class for about 10 years of my previous employment, and the impact of talking with leaders in diverse groups was powerful, altered our services, and I think as a state and as regions we need to do that. We found that we need to address the transportation issues. We had some public transportation in one of our counties that was threatened to be canceled because of COVID, and the group, the board that was looking at doing that was simply not addressing the disparity that was beneath that decision, and when advocacy occurred, that was changed. We had food shortages early on, and one of our departments at the state really dug in and addressed not the overall food shortage problem, but certainly access for some of our groups, particularly in AFCs at that time. One of our current strategies is that we have a diversity, equity, and inclusion contract expectation. And within our policies there, we also now have an RFP process that also reviews against diversity, equity, and inclusion plans. And also, it's one of our policies that the expectation is to have a direction in all of your service providers and in all of your contracts that a DEI plan is expected. And again, Brant could talk extensively about this, the policy and program changes. But if you look at the links that we attach to this presentation, you'll see that there are a number of links on policies that have already been changed. All right, let's move on to the last slide before questions, and that is some of our future strategies. So one of the things the DEI Council is going to do is, again, to go out and talk to people. That's going to be interesting to do that virtually, but we have 5 priority regions in the state, and our committee will have representatives talking to all of those regions. We do not think that one plan works everywhere, so we will be listening to what that particular region, that community needs. But what we are going to do is ask the question, are the services that you're getting meeting your diversity, your equity, and your inclusion needs? And that'll become our scorecard, and I suppose the scorecard for really the system at large. Lastly, we have to put our money where our mouth is. We can't just put out policies. We have to do the introspective work personally, and we have to do the work in our teams. And so every department within MDHHS, the Michigan Department of Health and Human Services, every one of our administrative groups is developing a DEI plan. And I could just tell you briefly that I have done 3 listening sessions with our 100 staff. And from there, we're designing our BHDDA action plan for DEI. And it's been a lively, painful, but important discussion. So thank you all for that. I know it's a lot of ground. I will leave it up to the host about the Q&A session, but that ends my presentation. I will say one thing, that if you have questions later on, like normally happens to all of us, my email address is attached, and especially while we're working off site, that's the best way to reach me. And every question is a good one, so don't be afraid to ask me those after this session if you'd like. Thank you very much.
Thank you so much, Mr. Jensen. That was wonderful. That was a great presentation. I am just going to check if there are any questions. Just wanted to let you know that you can raise your hand and unmute to speak. If you are calling, then please hit *6 to unmute. And you could also text us your questions at 248-330-1175. Again, that is 248-330-1175. One of the questions is, what specifically are the 5 priority regions?
Oh, I'm so glad that Brant's on the phone. That is one I don't know. But go ahead, Brant.
Okay.
Good morning, everyone.
Good morning.
Good morning.
Yes, thank you, Alan, for doing such a wonderful job with going over all the definitions, strategies, and current and future strategies as well. What we mean by 5 priority regions is the state of Michigan is divided into 5 different regions. We have the Upper Peninsula, the Lower Peninsula, the western side of the state, the southeastern side of the state, and in the northern side of the state. And so it's broken up into 5 different priority regions. We can supply a map of that a little bit later on or what have you, but it shows how the entire state of Michigan is broken up into 5 different regions. And this is how we basically do our work in the department, is that each region has a BSC, which is a Business Service Center Director. And the Business Service Center Director is assigned to each of one of those 5 regions in the Upper Peninsula, the Lower Peninsula, the western side of the state, the eastern side, the southeastern side of the state, and the northern side of the state. And that's basically how we have divided Michigan to be able to go into all of those priority regions with our community outreach project to talk to our customers and talk to our stakeholders in each one of those regions. Alan talked about us laying the groundwork for our contracts, our policies, and our programs, which we have done. We have inserted diversity, equity, and inclusion into all of our contracts within MDHHS, and MDHHS has over 5,000 contracts. So what we've decided to do is look at all those contracts and ensure that all of those contracts and those in any contract going forward has a diversity, equity, and inclusion lens applied to it, ensuring that all of our services provided up under the MDHHS umbrella are diverse, equitable, and inclusive, specific to each community's needs, because as Alan has discussed earlier, that each of our priority regions have very different needs. And so we cannot any longer apply a one-size-fits-all approach. We have to go into each of those communities, which is what our community outreach action plan is, and talk to our customers and talk to our stakeholders about what those specific needs are. And then we have to address them and make sure that the services that we're providing in each of those priority regions are diverse, equitable, inclusive, as well as specific to that community's needs. So.
Thank you, Mr. Wimbush. That was very enlightening, very informative. There is another question. Someone has raised their hand. I believe it's Dr. Rosen. Go ahead, Dr. Rosen.
Can you hear me?
Yes.
So I'm impressed with the work that the state is doing. And, you know, sort of like when there are cracks, the light comes through. So we have this horrendous pandemic, and we begin to see the cracks in the system. And as the light comes through, we come up with policies and procedures to try and address them. And some wonderful ideas are coming from the state. What worries me is how do we keep the initiatives going after the pandemic is over or after the next election, because there could be a whole new group of people, leaders in Lansing and in the legislature. How do we keep this going?
Well, that's a great question, Dr. Rosen. And how do we keep the work going? We knew that we had to address that issue early on because we know that administrations change every 4 years. And in 2015, our department merged with the department, MDHH merged the Department of Community Health along with the Department of Human Services, which created the Michigan Department of Health and Human Services. But both those departments independently were working on diversity, equity, and inclusion strategies. So what the department decided to do was to merge those two and to merge the efforts, and thus what created the Diversity, Equity, and Inclusion Council for the Michigan Department of Health and Human Services. And within that council, we were charged in 2016 to develop a diversity, equity, and inclusion plan that would breathe the life of diversity, equity, and inclusion into all of our work and all of our practices within MDHHS. So just to, be frank and honest, it took us 2 years to develop a plan that was going to be very comprehensive, but very doable for the department and sustainable for the department. So it took us 2 years to develop that plan. It was officially approved in May of 2018, but for 4 years, we worked on developing strategies for all 5 of the action teams. We have strategies for the leadership action team. We have strategies for the hiring and recruitment action team. We have strategies for the cultural development action team, culture and climate action team. We have strategies for the training and professional development action team, as well as the action team that Alan and I co-lead together, which is the service delivery action team. And within that plan and within those strategies, we made it abundantly clear that this was a plan for the department that would transcend all administration. So it does not go away. It is the fabric of what we do in the Michigan Department of Health and Human Services, and it will forever live in the work of the Michigan Department of Health and Human Services. Also, to just add to that, that plan has been submitted to the Department of Civil Rights as to this is how the Michigan Department of Health and Human Services will do their work now and in the future. So administrations may come and go, but the work of diversity, equity, and inclusion will remain in the Michigan Department of Health and Human Services.
Dr. Rose, and I'd like to just add that I think you're asking, your question is the one that we do worry about the most. And I think Brant just gave you a very detailed answer of what we're working on. My short version of that is we have to have the policy development behind that, so that it stays in policy afterwards in our contracts and in our action plans. So that's where I see our focus. But I share your concern about the danger of letting things erode when whatever the next crisis is or the next change is. So we need to codify it as much as we can in both policy and in law, as Brant identified. But thank you for raising that.
Yes, and I apologize for missing the question or what have you, but Alan is correct. That was one of the other strategies specifically for the Service Delivery Action Team, was to root out all systemic bias in all of our contracts and all of our policies and in all of our programs. And we've done that by way of law, as Alan has stated. Policies have been changed legally using Elliott Larson Civil Rights Act law to ensure that there's no disparaging impact on any marginalized group based upon the marginalized identities listed in Elliott Larson Civil Rights Act, as well as utilizing the governor's executive directives 2019-08 and 2019-09, as well as 2019-10 that deals with making sure that we treat all of our customers with dignity, respect, and make sure that all of our services that are provided up under the MDHHS umbrella are diverse, equitable, and inclusive, and not just diverse, equitable, and inclusive, but specific to each of the community's specific needs or what have you. And so we knew, based upon the research from other states, that administrations do come and go, and that it's easy for others to come in and decide that they don't want to provide services in that manner anymore. That's why we embedded the diversity, equity, and inclusion into the policies, into the programs, and into the contracts, so that they will live and breathe within MDHHS forever.
So, again, I commend you for what you're doing, but especially speaking up and letting us know and letting the public know where you stand on these issues, which I think empowers people to speak up, because one of the most gratifying things, of course, is when people can speak up and say, this is wrong or this has to change, and have the courage to do that, and to know people in leadership will be supportive of them and not demean them, insult them, degrade them, because we are a democracy, and we have elections, and people can vote. And if we keep these issues on the front line, I think we have a much better chance of whoever wins the next election will be advocating for these very same things that you're talking about today.
Thank you so much for that. And I think you've been reading our plan, because that was another thing that we did. We wanted to empower our staff as well. So we also wrote policy to empower our staff, and you can see in one of the slides that policy is APR 211, which was a bulletin, a policy bulletin update which is APB 2020-20, that indicates that now our staff cannot be retaliated against or harassed as they do the work of diversity, equity, and inclusion. And what we have to do now, which is part 2 of our implementation strategy, is to now go into all of our policies and make sure that the services that we're providing are diverse, equitable, and inclusive, specific to those community needs. And the only way we can do that is to go into the communities and ask. And the only way we can do that is to empower our staff to be able to assist us as we go into these communities and ask these important questions about the services that we're providing. And so we had to build policy to protect our staff as they do their work as well. So that was one of the things that we felt it was critical that we had to do, was to protect the staff up under the policy and up under the law, as well as protect the work.
Thank you so much. Thank you so much for the answers and all the information to both of you. We really, really appreciate it. And thank you for the questions as well. I will go ahead and introduce our next speaker. But before that, if I could please have everyone turn their microphones onto mute, because we want to make sure there's no background noise or static and everyone can hear well. So thank you so much. So the next speaker I have the pleasure of introducing is Mr. Kenneth Briggs. He's the Program Relations and Business Development Administrator for Meridian Health Services. Kenneth was appointed to the Region 10 PIHP SUD Oversight Policy Board by the Genesee County Commissioner's Office. For the past 25 years, he has served many capacities with the Detroit Lions organization and is currently a team leader for on-field promotions. He has a psychology degree from Oakland University. He is an advocate for substance use awareness to educate the community on addiction treatment, mental health issues, and diversity awareness. He has a great passion for helping others, inspired by his profound life journey. He has been recognized by the Oprah Winfrey Show, Dateline Detroit, and Guidepost magazine. Please join me in welcoming Mr. Kenneth Briggs.
Can everybody hear me?
Yes. Yes.
All right. All right. So today, I hope that we're able to have some. A part of my speech is going to be somewhat difficult to digest, and that's what I want it to be, because this process has to be somewhat painful to actually for people to understand. Individuals of color, individuals of different origins coming into treatment and how that works. So with saying that, a lot of times people don't understand how implicit bias, how prejudice and racism works inside of and outside of treatment facilities and inside of treatment facilities. So long time ago, I was a counselor, and I worked to thoroughly to work through issues with clients, and I had a long-term program with clients. And my daughter told me to put this in a speech. She's a 20-year-old mixed race young individual, lives in Canada, that doesn't experience the issues that we experience in the United States. That's not putting down the country, that's not putting down the thing, it's just our history. And understanding our history, you're gonna see throughout my speech that I'm gonna talk about those issues. So people, if you go to my next slide, people are gonna ask me, what does duck mean? And I'll get to the end of it, what it actually means. And it might be a little bit of surprise, and it might be a little bit hard to digest. But I used to have individuals, and I was overseeing individuals that were, beautiful young men that just had problems. criminal justice problems, substance abuse problems, all the different things that individuals come. Some of them were African Americans, the majority were white. I would always do these speeches because I've spoke all over the country, and I speak at a lot of different things. But most of the times I speak on trauma and how trauma informs you, how it makes you make decisions if you haven't addressed it. So I used to hear these noises in the background, this duck noise, and I just never understood what the duck noise was. And so when my young African American males were speaking, I always heard these duck noises, and I just didn't know what the duck noise stood for. And after learning what the duck noise was, a young man stepped up to me, a beautiful kid stepped up to me, and he said, "Hey, you know what that duck noise stands for?" And I said, "What does it stand for?" And he says, "Dumb, uneducated, colored kid." And at that time, I had been a counselor for about, 15 years. And my heart dropped. My heart dropped. It explained a lot to me. So I went on this endeavor to actually understand, because I never talked about race. I was kind of, a person that, that wasn't fully in tune, because I was guided by many different things, and I served on many different boards as a younger man, that wasn't my main topic of different things. And I seen how that influenced individuals inside of treatment, and how a person inside of treatment ends up in a fight because someone is basically discriminating against them and using this noise and using this term to have them basically either kicked out of treatment or having an adverse effect for somebody that's in treatment. So I went on this thing of understanding, and I don't have to get into consequence of the guys or all the different things and what approaches that we took to actually do something better, but just recognizing that it's deeply seated inside substance abuse and criminal justice programming. So when I talk to people and understand that I don't indulge in this in too much, but when we talk about black on black crime, actually that's a term that is kind of like it's no words to it, that it's racially biased when you say that. Prime example that I give to this, and all you have to do is just listen, is that we never talk about white on white crime. And I'll get back to that in another segment. But the tools that we use as counselors to know that they're weighted against African Americans and know that it's weighted against individuals of color, like the compass, like the PSI. And if anybody don't know what the pre-sentence investigation is, weighted towards implicit bias and actually a bad outcome. How do we know this? Blacks are no violent. They're not more to use drugs than whites. But when you go into the stats, you understand that 58% of African American males in Pontiac are under the judicial system. And if you go to other bigger populations like Washington, D.C., it gets up to 72% of African American males are under criminal justice, some type of jails or probation or parole. So if I can go to my next slide. Media bias. every day we're bombarded with media bias every day. If you look at the two different, if you look at the white males on the one side and you look at the black males on the other side, you'll see that it's totally different the way that people view this. And so you're bombarded with probably 20,000 of these every single day. I was just talking to, and I'm going to give you a solution to these issues, but I was talking to my, actually talking to my CEO last night, and I gained a little weight on quarantine, so I was trying to walk off and try to get to the point where I'm running to get rid of some of this weight. But I live in a upper or middle class neighborhood, and I was walking through and I seen a sign, and it said, if you call the police, this is by an investor, if you call the police, if a baby calls the police, the baby will get arrested for, or he will be arrested for not taking or resisting arrest. Sorry, I know I kind of messed that up. And I said, and so I later on I called the investor and I said, do you think that this is something that you want to promote inside your community? Is this something that you want to put out there inside of the community? And after we had the conversation, the guy was a God-fearing man. He was a very respectful, and he said, I never thought that I was doing anything wrong. And that's kind of some of the issues when I talk about DUC, when I talk about these billboards, when I talk about different things that they're invasive inside of your head, and it makes you actually make decisions on how you treat and how some people treat African Americans. Can I go to the next slide? So, implicit bias, how kind of it works, and I'll go into it, and I tell a lot of stories. So story time is my time to explain things, and this is how I've learned, and this is how I've had a lot of great relationships with some of the people, some great leaders in Michigan and throughout the country. My story time is this. My neighbor in my neighborhood went outside and he shot my other neighbor. And I live in a pretty affluent neighborhood because his grass wasn't being cut. How do you think the story was portrayed in the media? How do you think things were portrayed in the media? Well, it said, the story read, it's the first shooting in 30 years in the particular town that I stay in. So what's wrong with that? No one brought up black on black crime. No one brought up white on white crime. No one brought up anything to those situations. Actually, what they were doing was they were downplaying gun violence between individuals, and they were upplaying the issues with safety in the neighborhood. Like, this is not something that happens all the time. So it sends out mixed messages to people in the community. So when I get to a implicit bias, you can read the definitions to implicit bias, and I know that everybody understands that, and it's a whole class that you could take on implicit bias. And when we talk about things that we talk about this in different things, and how does this affect individuals? So I'm going to give you some careers that you might be upset with when I say this, that when I find that people have the most implicit bias in these sections. And I will say real estate agents. Everybody's going to say, why are you saying that? We are the most segregated, especially in the North. We are so segregated in the North. People think it's the opposite, but actually when you live in the South, you have more of a chance that you might live in the neighborhood with all different races. The next thing that I said is counselors. a lot of times counselors have implicit bias when they make decisions. The way that you hear this all the time, the way that the person said something, or he was being aggressive with his talk, or he was talking with his hands, or he was talking with whatever. We have to get rid of that, because that's more of a cultural issue than it is a violence issue, or somebody was being disrespectful to you. And that goes into your decision making. And the next thing I want to bring up, and this is even more controversial that I'm going to bring up, but I'm going to give you a solution to all these different problems. Preachers. Why do you say that? My friends were golfing the other week ago, and there is a preacher that's golfing with them. They didn't know he was at the time. But this guy says, black people are always killing each other. These are direct quotes. Mexicans are rapists, and they're trying to invade our southern borders. Protesters should be shot at sight. My friend gets off the golf course and he asks me, he says, who is the guy that I'm playing golf with? And I said, he's one of the biggest preachers in the state of Michigan. I'm going without names and different things like that. But it says that. You ask that question. You're in a role to actually help individuals, and you have those biases and you have those issues inside your head, but you're also in a leadership position that you can't understand what you're saying, is very hurtful and very prejudiced in some of your ways. It might even borderline on racist. So understanding that. So let me get into my next slide. Cultural differences. Now, this is where I find that a lot of people actually get into a lot of issues and a lot of problems. I view myself, yes, number one, as an African-American man, but I view myself as a Midwesterner. And I have a lot of values, beliefs, patterns, and daily things that I do that are with Midwestern values. What do I mean by that? Understanding your culture. Your culture is what you do. For instance, my hobbies. And people always hear about my hobbies because I'm always in meetings and I'm always talking about these things because I love these things and they're my passions that I do. Ice fishing, boating, swimming, and triathlon. You probably couldn't tell by my weight size, but I do get out there. Can I swim? Yes. So the cultural definitions of those things and understanding the cultural definitions and breaking things down. And sometimes people ask questions and they ask questions and they don't know that they're being culturally insensitive when they ask these questions. Well, you ice fish? Yeah. I ice fish. I actually love it. I love sitting in the shanty and ice fishing. But you're asking these questions to a professional. You're asking these questions to an administrator. You're not asking these questions. So what kind of questions are you asking if you're a counselor, if you're a case manager, or if you're in charge of someone's life? If you have no education and you don't know that those questions are biased or are deflating. I had a friend that said, and they still friends, that his other black friend gave him the permission to say the N-word. No one can give you the permission to ever say the N-word. I know that, in these times you probably wouldn't say it, but some people still say this. So and one of the things that you hear people always say it, and it's so upsetting to me. I learned my vocabulary and I had my vocabulary fixed by being raised in Canada at a later age. You sound like you're white. No, I sound like I'm from the Midwest. So understanding these issues to actually to downplay and to actually get through this. So story time. Approximately at 14 years old, as a young man, I lost my parents when I was a younger man. I didn't go to both of my biological parents' funerals. I reburied my mom in Gulfport, Mississippi, and I searched for my father's grave for a long, long time. He was a World War II veteran. So I went into the town to search for my father at a later age and search for his grave, just to do some soul searching, just to do some getting rid of some different things inside of my life. And when I went to the graveyard, I searched every gravestone in Mississippi, in this town. And then I went over and I asked at the Winn-Dixie, and if anybody ever been to Mississippi, Winn-Dixies are like Tim Hortons or Walmart's or whatever here. It's one on every dead and dollar stores, General Dollar, sorry. So I went over to the store and the lady said, "Why are you in that graveyard? That is a white graveyard. That's not a black graveyard. Blacks are buried somewhere else." So the question that I asked you, and the question that I challenge you with all the time, is that even to this day in parts of America, you might not know this, that blacks and whites are not even being buried in the same cemetery at this time. You talk about equal rights. You talk about equal rights right now in America. If you're not even buried together, how's that possible? So how do we move forward? How do we move forward with this thing is that some of my great role models ever, my CEO is a great role model. His name's Rick Page at Meridian. He's a role model. His father of him was a great, Bernie Page was a great role model to me. Fred Mester, these are all white guys. Great role model towards me. Great role model, Ruben Mondane, black man, attorney, and whatever. But I was willing to learn from these individuals to actually get out from some of the stereotypes and learn some things from me. Now, understand this. As an African-American man, anybody that's listening, or African-American woman that's on this line, you have to be in the board positions to actually make change. You can't make change if you're not part of the conversation. And for people that are not of color, you have to talk to the individuals in your communities that are not of color and explain the pain, explain the hurt, explain the different things that goes on with African Americans. And I'm saying this, it brings tears to my eyes because, you know, my daughters, I got some young daughters, and they don't have those biases. And the first time that they ever asked me a question about cops, and they're 9 and 4, and my daughter asked me, she says, "Hey, Dad," she's like, are the cops gonna kill you? And I said, "No, baby." And that's trauma, even for a 9-year-old, because she never had the burden that putting on this suit, and when I mean putting on this suit, putting on this black suit ends up. So how does it affect us inside of treatment? We have to be aware that every time that an African-American or African-American individual enters our treatment facility, that we are aware of all the situations. What I hear people say, that we treat people always equally. Something's wrong if you say that you treat people equally, because it doesn't exist, the equal. So everybody has biases. I hear hear certain things from Black friends that are just outright abhorrent and just wouldn't be talked about. And I hear things from Black friends that are just professional people that are just absolutely abhorrent and that you wouldn't even, I mean, we all would be fired by some of the things that that people say. But giving people a chance to make mistakes, giving people a chance before you lower the hammer on them, given an opportunity to actually understand. It's very important that we move into this, because if you understand this, is that, and I know this because I grew up in a household where the toilet bowls froze in the wintertime. My mom told me that social workers and counselors were just like cops. And most African Americans, parents tell them somewhat of the same thing. And why do they tell them that? Because they were back in the early 90s and the 80s and the 70s, they were there to cut off checks. They were there to cut off payments. They were there to take kids away. They were there for some other purpose, reason. So you have to be sensitive, and majorly sensitive when someone just any diversity comes into your treatment facility and into your thing. I'll give you a prime example. They might not tell you, but they tell me all the time. Probably 90% of all individuals that enter a treatment facility point out some kind of racial disparity that's going inside of treatment. And that's no matter what treatment facility I am in and what place I'm in, that probably 80 to 90% of all African Americans point out something, either on a daily basis or during the time that they're inside of treatment. Another thing is that African Americans don't go to treatment. They don't. They would rather, in most cases, go to jail than actually go to treatment. So what are we doing wrong there? How are we not warm and welcoming? How are we not informed of these different things? So we can get all through this. We can by joining together. And if you go to my next slide, increasing your contact and opportunities. How do I do that? On a daily basis, I join boards, I join different places in my community, and I often tell people that are not of color to actually do those things, and you will get a better perspective on both sides on how do you move forward. Increase your contacts, it will give you better decision making, and it will give you it will decrease the stereotypes that you might have inside of your head, and it will also give you opportunities to learn more and treat your clients and treat your people better inside of the community. So with that, I'm done. I'll take any questions if anybody has any.
Thank you, Mr. Briggs. That was very enlightening. That was really, really good. I am just going to wait to see if you have any questions. And again, you have to press *6 to unmute. And if you have any questions, you can also text them to us at 248-330-1175. Someone's saying great presentation.
Thank you.
Did I miss any questions? I'm just asking my team members. Another person is saying, thank you for sharing all your stories. I also really liked all of your stories. And I have to say the DUCK acronym, I had never heard of that before. So that was
Yeah.
interesting. I'm going to share it with the people I know and see if they've ever heard of it.
Yeah, I had never heard of it either, but it's pretty painful
Yeah, yeah,
to
yeah.
actually go through. But after you learn from that, it brings you a lot of you know, and it's kind of funny that you don't hold a grudge,
Mm,
after that. It's pretty funny that, I don't I, I don't tell the story that much. It's probably the first time that I ever told it in a group setting,
uh-huh.
but you you just don't hold a grudge because you got to move forward, and hopefully everybody that's here is trying to move forward and push the society to a better place, and I think we can. I really do.
Absolutely, absolutely. You have to use these as teachable moments. I do have a question now from Amy, and she is asking, she is saying that I would like to hear your perspective on the current momentum of conversations around race. I know many are fearful this momentum will not last.
Um, and I learned this actually from an NFL guy, and he says that how you make things last is that you pick three things that you want to be in charge of. Is if you really want it to last, pick three specific things, and then you tackle those different things. So every week, I pick a certain thing with race and racial inequality, and I pick those things and just those three, not more than that. I'm not trying to bite off because I got kids and wives, wife, and different things to fulfill. That I push forward, and that I want to handle. And with those three things, just like the little thing that's in your community, that a young African American male doesn't have to drive by and be insulted by a sign that comes inside my community. I have control. I don't have to protest. I just have to have conversations with individuals. And most time when you can have conversation with intelligent people, with people that understand, they will make that adjustment every single time. And that's the great thing. So I know I only have 15 minutes, but I can talk all day. So thank you for
And we could probably listen to you all day. We do have another question. I believe it's Pam had raised her hand. Pam, did you want to unmute and share your question?
Sure, it's back to the duck acronym. Did people actually say the word duck, or did they make the quack sound?
Oh, it was all different types of things. I thought I was in a zoo for a while. So
Yeah.
yeah, it was both. Yeah. And then
Oh.
and don't go looking for that duck acronym because you're probably not gonna find it.
No.
Don't chase your tail.
No, I was just curious if it was they
It's not
sat
even
in class
good.
and they said duck.
Yeah.
Said
Yeah.
duck.
And so what I'm getting with that is systemic
Exactly.
racism. That
Right.
that acronym means so much more because that determines because when you have a whole group that's doing that, it's pushing the marginalized people out
Right.
and making them react in maybe sometimes even in violent ways that they normally wouldn't act to. And so if you have enough enough power to actually put that together and carry that on for a long period of time, it is devastating. And you'll see better results and better improvement rates if you're able to educate alongside those different things and educate people on culture and different things like that. So it's important.
Imagine if it was a positive impact.
Yeah, well, yeah. Imagine if it was, yeah.
Yeah.
That would be
Thank you.
wonderful, really, wouldn't it? And if the individuals had came up with it themselves, that would be
Yeah.
that would be a beautiful thing. It would be just probably one of the stories I would tell all the
Yeah.
time. Yeah.
Yeah. Thank you.
Thank you. Thank you so much. there's just so many people. There is Rita from a Latino family. She's saying thank you for all the information. Another person is saying, thank you for the tireless advocacy you have provided. So we really, really appreciate you joining us today, Mr. Briggs. That has been really wonderful chatting with you and learning from you. So we
Thank
really
you.
appreciate it. And next, I believe, is Kenyetta.
Good morning. My name is Kenyetta Brewer, and I'm a cost and utilization analyst on the budget and finance team here at Oakland Community Health Network. I have the pleasure of providing a brief history of soul food and introducing our next presenter. Soul food is an African American style of cooking which originated in the southern United States. Traditional dishes include fried chicken, collard greens, yams, and baked macaroni and cheese. You'll find similar dishes in Southern cooking. However, soul food is set apart by its bolder flavors and use of seasonings. This was born partly out of necessity. Often, enslaved Black people were not fed quality meat and produce, but received rations of salt cured meats, discarded animal parts such as necks, tail, feet, intestines, and starches like cornmeal or rice. They supplemented with foraged ingredients and what they could grow on their own, including West African vegetables like yams, okra, black-eyed peas, and greens. After emancipation, African Americans continued to use animal fats, salt pork, and seasonings to transform humble ingredients into delicious meals. During the Great Migration, which lasted from 1916 to 1970, many Black people, like my grandparents, left the rural South for economic opportunities in the North and West, bringing their recipes with them. Today, people like our next presenter, Chef Q, are adapting traditional recipes to make health conscious comfort food, like her vegan mac and cheese. Chef Kiana Q. Broden is a renowned chef and vegan food blogger that has 15 years of experience in the food service and entertainment industries as a personal chef and food connoisseur. Through existing relationships with local, social, and community groups, ongoing relationships with specialty grocers, her elite clientele, she has pushed forward her mission to teach people how to eat to live by introducing more plant based meals into everyday living. With demonstrations and living recipes, Cooking with Q has become the space to allow vegans and meat eaters to coexist. Next, we will have a cooking demonstration by Chef Q, followed by Q&A. If you have any questions during the demo, please feel free to type them in the chat or text 248-330-1175. Please help me welcome Chef Q.
Oh my God, they're making the fresh mac and cheese. Oh my God, the making the fresh mac and cheese. And it's gonna be awesome. Yeah. Okay, so I'm bringing you guys into my vegan macaroni and cheese recipe. I know everybody, like when I go to different shows, they love this stuff, right? So I am having a huge gathering and everybody wants to have the vegan macaroni and cheese, so I'm gonna make it, but I'm making a huge ton. Now, when you guys are making vegan macaroni and cheese, you're not gonna use as much noodles at all. You'll probably use a regular box, the little 16-ounce box, totally fine. With that, I'm gonna break down the recipe for you guys, although I'm showing you how I make this huge, massive, massive pot. My noodles have cooked, they are absolutely perfect. I'm obsessed with them. They look super happy, they are ready to go. I am going to dump about, in your batch, you're gonna put 2 bags of Daya. And if you want it to be overly cheesy, you can do more than that, but 2 bags of Daya is usually what you need for like a regular 16-ounce, boiled box of noodles. Whether you use noodles or shells, it's the same recipe. And again, some of the stuff I put in mine, if you want to alter yours, go right ahead. This is just what I use in mine. It's really simple, but it tastes so good and everybody loves it. So right now I'm going to go get my soy milk. I use soy milk. Today I'm using soy milk. Sometimes I use almond milk. When we're cooking for people where it's just in my house, I can use almond milk. It's not a big deal. But when you're cooking for other people that have allergies, some people you'll see more nut allergies than you will a soy allergy. So for me, I'm gonna put soy milk in here. When you guys are actually making your own, you're going to use, if you got like a half gallon, you'll use half of the half gallon. Okay, so I'm gonna grab my soy milk and dump in here. Also, douse it with some salt, some pepper, and I like to use the Himalayan sea salt. It makes me super happy. I do use some garlic salt or fresh garlic. Your choice is whatever you have on hand. For me, I'm all about, I want to use everything that I have. I don't like to waste things, and I don't want seasonings to be sitting around like forever. So I'm gonna get this popping, and then we'll go to the next step after I get the soy milk. Okay, boom. So I kind of set some of the ingredients out for you guys to see. I got some organic soy milk, and I have, Daya gave us some awesome, the shredded cheddar, and then I have 2 of their cream cheeses. Now for you guys, you're not making this huge bulk amount, right? So what you're gonna do for your 16-ounce package is, like I said, you'll use half of a half gallon of milk, and you will know because you just want it to be a creamy, consistent texture, right? You don't want it to be dry. You want it to be creamy. Then on top of that, I'm using my Daya cream cheese. It's amazing, it works, it adds to the creaminess. When I use my Daya shreds, I like to combine them both because it makes the texture of the macaroni like creamy, and that's what you want. Like, you don't want it to be dry. Because I've had some dry macaroni or some dry vegan macaroni, and I was like, oh, this is not like mama's. No. And that's why I was like, let me make my own recipe. And ever since I created my own recipe, we don't even make regular macaroni and cheese in the house anymore. We make regular macaroni and cheese is our vegan macaroni and cheese. And it is a hit in our family. So that's why I had to share it with you guys. Because what's the purpose of having an amazing recipe and not sharing it, right? So I'm gonna add my soy milk to this, and it's all fresh and new and organic, and I'm just gonna let it do what it do. I tell you guys, I know this is a lot. It is a lot, but there's gonna be a lot of people eating this. So, welcome to me cooking bulk. Now I am going to just stir this around because I want to make sure that it is juicy, because if it's juicy, it'll stay juicy, but if it's dry, she gone. She is gone. Okay. So this is gonna be good. We're gonna add one more here. Look at that. Happy noodles. And now we are gonna add our cheese. You guys, like I told you before, you're only gonna put in like 2 bags. But because I have so much, I am using about 5 bags. All right. Now, like I said, you want this to be cheesy. When you guys make yours, you'll probably use like 2. If you feel like using 3, you can. For me, I am making sure we have enough. You know how I am. The ratios have to be right. The cheese to macaroni noodle ratio has to be right. It can't be macaroni and cheese if it's not cheesy, bro. That's perfect. So what we're gonna do is we're gonna use 2 things of Daya cream cheese. And now for you guys is what I was going to tell you, like when I make my own personal, it's not this huge. I make it super easy and creamy by mixing a half of a Daya cream cheese and a half of the tofutti sour cream. It's almost just like how we made our insides for our stuffed shells. You just want it to be creamy. And we are making this large amount, so I am going to add the extra in here now. Get that in there, get that out of there. And this is just going to make it creamy, because for me, when this recipe, mind you, I started making vegan macaroni and cheese when they first told me that I was allergic to dairy. My biggest thing they said was like, you know, you can't have dairy. And this was on top of finding out that I had sarcoidosis, which is like an autoimmune disease. But my goal was, you want to take dairy away from me? Like, my mama makes the best macaroni and cheese I've ever had in my entire life, and you want me to tell me I can't have it anymore? And that is a weird place to have to be, but guess what? Going vegan doesn't mean you can't have things that are flavorful. It just means you have to remember the flavors that you had. So I remember the flavors that were in that macaroni and cheese, and instead of me adding a bunch of eggs, a bunch of butter, I created this recipe, and it works. Like, everybody loves it. I have yet to meet somebody who does not like it. So now when that bakes up, not only is it going to be as creamy as it is now, it's going to be even more creamier, because now that vegan cheese can melt. The Daya can melt. It's going to be amazing. Woo! Lord! Good Lord, that's a lot of pasta. We should be happy, but now I'm going to add some seasonings to it. I am going to for sure throw some fresh parsley in there, just because look at that. Tell me that's not pretty. It's so pretty. I'm gonna dice some more. Hi, Fresh Herb Keeper. Can I have some parsley? Thanks. Appreciate you so much. That's just gorgeous. That's beautiful. Are you kidding me? Seriously? You don't want to eat that raw? Straight up? This is about all the red pepper I'm gonna put in this entire pot. It's a lot. It's fresh crushed. It's like dried out. It's hardcore. So we're not gonna put a lot in here, because everybody they will go crazy if I put more than this in. So we're gonna sprinkle that all around. We're gonna get our fresh pepper meal. Now we're gonna add some of our sea salt. Boom. I've had people like, oh, cute, I made your vegan macaroni and cheese recipe. They added vegetables, and it looked amazing. So if you guys try to make this recipe, tag me online. Let me see what you guys did, because maybe you'll make me try something different. I'm open to it. Hello. Yes, I am that person. I'll buy a crap load of seasonings and dump them all together, and they will taste amazing, and you will love it. One cool thing about this vegan macaroni and cheese as opposed to my mama's. My mama's, I would try to sneak and eat it. You know, she was putting like eggs and milk in hers before I was vegan. But like this, I can taste this before it's put in the oven. It's like my favorite thing. And doesn't that smell good? It smells amazing. Like, it smells amazing. I'm asking you guys, does it smell good? Like, you can smell it, because I get so excited. Now, the pan that you're gonna put this in to bake it, you're gonna bake this for a bit, maybe like 30 minutes. When you put this in a pan, you are going to want to, and this is something I like to tell people so that they pay attention to the difference. When you make vegan macaroni and cheese as opposed to regular mac and cheese, if I put vegan macaroni and cheese on a plate, when I go to the sink to wash it off, it washes off. You know what? That's what it does in your insides. If you make regular macaroni and cheese, and I'm not hating on those who are not vegan, I'm just telling you the difference. These are facts. That's what I give you. Facts. If you try to rinse that plate off, it's not going to rinse off. And you know what? That's exactly what's going to do in your insides. And my insides are happier because it can pronounce the stuff that's on the inside of it. I am going to put this in its pan. First thing I'm going to do is I want to spray it. And I'm using this huge pan because, like I told you guys, I'm feeding a lot of folks. So I'm going to spray this with like my olive oil spray so that it is easy cleanup. I'm a mom first. You guys already know. I don't want to do dishes. I'm going to start putting a couple scoops in here to lighten this load, because this is a lot. And sometimes we're super sassy. We will top this with like a sriracha, or Daya has a vegan ranch, and it tastes awesome. Always ahead, every time. 20, 30 minutes, okay? I hope you guys love the recipes today. The vegan macaroni and cheese, the vegan stuffed shells. Both recipes were amazing. I hope you guys got some great tips. My biggest thing is to make sure you guys know that just because it's vegan, it doesn't mean that it has to be bland. Find the things that make your taste buds happy. Now, if you decide to make these recipes, you know where you can find them. They're on the site. That's www.cookingwithq. That's Q-U-E, because that's me.com. Again, it's www.cookingwithq.com. And like I tell you guys, if you make that recipe, tag us on any social network. Hashtag cooking with Q. And until next time, may your taste buds be forever satisfied. Goodbye. Goodbye.
Wow, that was amazing. I'm hungry already. In case you guys missed it, we did put a link in the chat to Chef Q's site where you can get the recipe online. And we're so excited to have Chef Q joining us live from the kitchen. Welcome, Chef Q. It seems like you're muted. Go ahead and unmute yourself so we can hear you. Let's see, it looks like you're still muted. Oh, okay. Press *6 on your phone to unmute yourself on the phone too.
Yay!
Okay, hi. Thank you so much. That was amazing.
Hi, everybody. I'm so excited.
Me too. We're going to take questions now. Please put your questions in the chat or use the raise your hand feature and unmute to speak whenever you're called upon. Also, if you're calling in, please hit *6 to unmute yourself. Or if you'd like to text your questions, send it to 248-330-1175. We've already got a couple questions in the chat.
I'm excited. I'm excited.
Okay, so our first question is from Amy. She wanted to know if you only prepare vegan foods.
No, so when I created the Cooking with Q is a place where vegans and meat eaters could coexist. Because for me, I came from a background where all of my family is from South Carolina. Honey, they eat everything from the rooter to the tutor, okay? So me going from being a meat eater to a vegan, it was kind of rough because sometimes you meet vegans who are like, PETA, don't touch a whale. Don't wear fur. Don't bother the leather. And the meat eater's like, girl, you're going to die if you go vegan. It's not going to work out for you. And I just wanted to be happily in the middle because I knew I had to eat healthier because I wanted to live because I found out I had sarcoidosis. So when I created Cooking with Q, it was a place where vegans and meat eaters could actually coexist. So I don't force veganism upon anybody, but my goal is just, my entire mission is to show people how to eat to live by introducing more plant-based foods into their everyday living. So I cook for everybody. When you come to the kitchen, we serve food for vegans, meat eaters, and everybody in between. So everybody's happy, but it's just a healthier version of some of the things that you might want.
Great. Oh, and I'd also like to add that Chef Q does have a restaurant called The Kitchen. It's located on 6529 Woodward Ave in Detroit.
It's so cute. It's so cute.
It's beautiful. Oh, we have a couple more comments. Someone said that if we were live, they'd be asking for samples because they are drooling.
Listen, so good. So good.
So feel free to stop by the kitchen. You can you can get a taste.
And today's Taco Tuesday. We got $2 tacos. $2 Tuesday.
Oh, someone else said that the salad that they brought for lunch is no longer appetizing.
I'm here for you.
Someone's excited about sriracha.
Spicy. That means they're spicy. I'm a spicy gal. I like spicy.
Right. Let's see. Let's see. Someone said that they enjoyed your essence in your presentation. You're comfortable in your own skin. Um,
I love food, and I'm
yeah,
always hungry. So this will
right.
work.
Some of the comments that the mac and cheese looked yummy. They loved your
It's
energy.
on the menu every single day. That's like one of the first things that I learned how to cook. Everybody was like, I had never tasted a vegan mac and cheese that was like good. Like my mama, rest her soul in heaven, she made the best mac and cheese ever. And like, if you're saying you're gonna make vegan mac and cheese in my family, honey, it better taste good or they're gonna talk about you like a dog. Okay?
Right, right. Oh, we have another question. Someone wanted to know, how long have you been vegan?
So I'll be 42 this year. I started my vegan transition. It's probably been like almost 8 or 9 years now.
Wow, wow.
Because I found out I had sarcoidosis. Sarcoidosis is so weird. It's the same thing Bernie Mac died from. So you have two choices. You're either going to eat to live or you're going to like push yourself over the edge because they want you to take like steroids. Like it was like 3-4 times a day and I was just not into it. And I'm totally not against doctors, but my first thing is always, how do you, what is a holistic way for me to try? What's that approach? How can I find a way to make myself feel better without taking a bunch of medicine? I did start taking the medicine, but once I started realizing that I could eat, change my diet, and it would actually change the output of what my circumstance would be, it made me, I don't have to take the medicine at all.
Mm-hmm, mm-hmm.
So
That's
yeah.
great. Oh, we have another question.
Thanks, Trisha. Come on, not a phone number. Trisha, thank you, girl.
Oh, someone wanted to know, what are some of your favorite brands of vegan cheeses?
I'm obsessed with Daya, and I know sometimes people have a bunch of. I like Daya. I try everything. I'm gonna be perfectly honest. When I make like mac and cheese and stuff in the store, we use a lot of Daya. Daya has been something that I've been using since I started my whole vegan transition, and they've always been friendly to me. I like real mom and pop stuff. So like, even though Daya is like this huge, like worldwide company, they're very local. When I call them, I can talk to a human. They are, and the craziest part is I think they started in Canada, but they're super, like you call and it's like you talk to a human. They're like, hey girl, hey. They told me I was saying it wrong because I was calling it Daya, and they were like, nobody wants to eat something where it's going to make you want to die, but it's a Daya. But if you say have a great day, I was like, oh my God, you guys are so corny. I just loved it. And it works. I know how to cook with it, but I've tried a lot of the vegan cheeses. They just have no soy, they have no nuts, and they have no gluten. So like you find people with many of those different allergies. People have nut allergies. They all have soy allergies. They all have gluten. They can't have certain things, and that is just something that it doesn't have anything in it. And I can pronounce everything on the back of the package. That's my rule. Like if you can't pronounce it, like you probably shouldn't eat it. So because your body won't know how to break it down.
All right, we have another question from Amy. She wanted to know about your perspective on soy, as far as whether it's safe. And she said that soy helps to regulate her blood sugar. So she just wanted to get your opinion.
So I'm an honest person, so I'm gonna tell you my truth. You get a lot of I'm a tester of things that people say. A lot of times people give you their opinions on things, and it's not like factual data. You know what I mean? It's not like we just do stuff because somebody told us that. We make the food we make because somebody taught us how to make it. Nobody's actually fact checking. It's like going to church and the preacher's preaching and he don't have one scripture. I'm not following you because he's not making sense. So for me, when it comes to soy, I tell people to do everything you have to do everything in portions, not overdo it. If you don't overdo anything, it can be horrible for you. You have to know the difference between a regular soy and non-GMO soy. There's GMO soy where it's genetically modified. So it's something that is man-made and created. And then there's soy that is like, it's organic and it's natural. So I am not against soy at all. It's not something that I tell people to eat it all day, every day. Like, no, that's not what I'm telling you. My rule is always 70-30, 70% fruits and vegetables, 30% everything else. The 30% is anything. It could be something processed. It is just, make sure when you look at your plate every day, it should be 70% fruits and vegetables, 30% everything else. If you come here and you're like, Q, I want to get an hell yeah burger. I know that burger is processed, right? But I'm not going to overstuff you with processed food. You got a side salad. Your sandwich is filled up with, fresh kale, tomatoes, pickles. I give you a lot of I give you a lot of your 70, so you don't have to look for it on your plate. I make sure your plate is 70-30. So soy is not bad for you. I know my husband's like, I'm like, you're not going to grow a boob, because, sometimes the guys will be like, I can't eat soy, I'm going to grow a boob. Like, you're not. Relax, calm down. Nobody's feeding you that. Like, you're not eating soy every day. Like, relax. So I'm not against soy. I just do everything in moderation.
Okay. We have another question from Mike. He wanted to know, how has your tone, personality, delivery impacted you in this business when facing others' biases against African Americans?
I don't think people are not used to a Black chef talking about being vegan. I'm just gonna give y'all we just real transparent over here. It doesn't bother me because I am true to myself. I'm a very big, I'm faith-based. The good Lord told me I'm supposed to show people how to eat to live, so that's what I do. I'd rather follow the directions of my Father than to feel the wrath of him. So in my head, I'm okay with showing people how to eat to live, and I can be for everybody if I can't be for everybody. Sometimes you got to realize you can't satisfy everybody in the universe, but do your part. I'm doing my part to make sure I'm teaching my community to eat to live, whether you like it or not, or because sometimes I tell people, I give it to people raw. I'm not going to sit here and put a scoop of ice cream on a pile of poop, because when that ice cream melts, it's still poop. Okay, I'm not eating it. Are you? No. So I'm going to be honest, and I'm just going to give you the honest, factual data that I have. People are receptive. When I first wanted to open the kitchen by Cooking with Q, there were a lot of people who were like, nobody's going to want to eat healthy. They're not going to want to do it. But I'm honest. I'm pretty sure the good Lord didn't tell me to teach my community how to eat to live, and nobody was going to come. And now, people love us, and I think people love us because they're like, when I get with Cooking with Q, or when I come to the kitchen by Cooking with Q, it's really good food. They give me, the people are there. They're here to help. We're just wanting to make sure that people understand, what you put in your body is what you get out. If you put healthy food in your body will react that way. But if you feed yourself a bunch of crap, you have to understand, that's why you're dealing with the circumstances. So,
Awesome. Thank you so much for joining us today. Could you tell the people one more time, where you're located and how they can order food?
Okay, family. So if you were looking to check out recipes, we have two websites. The recipe, if you want to see recipes, you can make them yourself, because I try to meet people where they are. You can just visit www.cookingwithque.com, and that's cookingwithque, because that's me.com. And if you want to check out the restaurant where you can see our full menu, we do vegan brunch on Saturdays. It's super dope. That website is www.thekitchenbycwq.com. And again, you got our restaurant, you got our blog sign up. We send you guys discounts. I call them coupons because I'm coupons. But there's tons of good stuff. We do meal preps for people because I try to meet people where they are, so you don't make an excuse of saying I can't eat healthy, it costs too much. We do affordable meal prep where you can come and get 7 days worth of food, 3 days a week. We'll bring it to your doorstep, contactless. We're known as the cleanest kitchen in Detroit, and there's a reason for it.
All right, awesome. Thank you so much for joining us today.
Thank you, family. Thank you, family. Have an awesome day.
Thanks, you too. Next, I'm going to turn it back over to Nada.
Nada, you're muted. I'm sorry, we can't hear you.
Okay, everyone. Looks like Nada's having some issues with her mic. Can everyone hear me?
Yeah.
Yes. Okay, great. This is Suzanne Weiner with OCHN. So I'm going to do this introduction. We're running a little bit behind, so we're going to skip our break. If you need to get up and do anything, you can do that because you're at home and you can do whatever you like. So we're going to move on to our next speaker. And hopefully we'll get some of our technical issues with Nada fixed as we move on. It's my pleasure to introduce our next speaker, Melkaya Newman.
Hello.
Oh, Nada, you're back just in time. Okay, we might have lost her again. I'm going to go ahead and introduce Melkaya. Melkaya is an OCHN board member, and she is the team supervisor at CNS Healthcare, the anti-stigma program. She has been a board member for OCHN since 2007, and she is also part of the Minority Mental Health Awareness Event Planning Committee. I'm going to let her talk to you a little bit more about herself and explain further about herself. Please join me in welcoming Melkaya Newman to provide her personal perspective of minority mental health awareness. Welcome, Melkaya.
Thank you so much, Suzanne, for that beautiful introduction. Hello, everybody. And I always, I've gotten used to presenting for quite some time, and people always ask me, are you going to sing? So yes, I'm going to open up with a little bit and close with a little bit. I was born by the river in a little tent. Then I go to my brother. I say, brother, help me, please. It's been too hard living, but I'm afraid to die. It's been a long time coming, but I know change gonna come. Oh, yes, it will. Suzanne, I don't know who's working the slides, but they could go ahead and start my slideshow, please. Thank you. This is my own personal perspective. As my introduction said, I am a person living in recovery from living with bipolar disorder. Next slide, please. And I'd like to start out by talking about myself. This is a picture of me when I was 18 months old. My birth name was Regina Lane Hoover. And I'll tell you a little story about that. All through school, I was teased for both of my names. They used to tease me for being my first name, Regina, comparing me to Regina Electric Brooms, and my last name, Hoover, to Hoover Vacuum Cleaners. So I swore as a child, as soon as I got old enough, I was going to change my name. So I looked up Melkaya Jeannie Maisha in a Swahili dictionary, and I changed it legally in 1972, and I've been Melkaya now more than I was Regina Hoover, but I still answer to my own name. That's a sidebar. But I show this picture because my mom tells me the story that when she was taking me to the photographer, I was the oldest of 5. She was taking me to the photographer, and she didn't know when she took me if he was going to be able to make me smile. Because at the age of 18 months old, I had never smiled. And this is the first smile on record for me. Next slide, please. So you know that being a baby, babies smile. I would have been a candidate for infant mental health if it had been available back in the 50s, but it wasn't. And mental health conditions do run in my family. So talking about the civil rights movement. The civil rights movement started a little bit before I was born. Brown versus Board of Education was in 1952. And after that, Dr. King took the center stage and led up the civil rights movement on behalf of African Americans. But there have been several groups that have championed their rights, women's rights, indigenous people's rights, LGBTQ rights. So being born in the 50s, I've seen and gone through all of those different transitions. We've seen some changes. We've seen some gains. Even recently, the Supreme Court upheld that people from the LGBTQ community could not be terminated from their employment because of their gender preferences. That was huge, especially in the climate that we're living in right now. So we have seen some change, but it hasn't been lasting change. Next slide. Trauma is the product of struggle and pain. We don't like talking, and I have enjoyed all of the speakers that have come before me. But this is a very, very difficult conversation to have. There is a lot of pain and a lot of hurt that has taken place in many different marginalized communities in this country. And it's hard. And I appreciate so much when the last speaker talked about talking about your pain to other people. But sometimes it's hard to talk about. I went to lunch with a good friend of mine. She's a Caucasian woman. She's worked in the community for many, many years, recently retired. And she asked me out to lunch. I didn't know why. And I was very surprised because when we started talking about what was going on now, she was angry, very angry. Angry that people were talking about defunding police and angry about the protests that were taking place. And at first I was a little taken aback, because she was a good friend. But she trusted me enough to share her struggle with all of this and wanted to ask me questions. So I was glad that we had that opportunity to have the conversation. Next slide. It's very common to hear people say, all that was in the past. Do we have to talk about it? Can't we just move on? I didn't own any slaves. I wasn't a part of what was happening back then. Why should I pay? Why am I being blamed? My question to you is, can we be brave enough to get past all of the emotions that are, this issue is very charged with emotion. Can we be brave enough to push past this, to have some honest dialogue and press forward for lasting change? Next slide. We can't just move on. It's not that simple. I like this quote. Just because you don't understand it doesn't mean it isn't so. Just because you haven't had my experience doesn't mean that my experience isn't valid. Many times people have a real hard time listening to the struggles of people of color. It's not that easy. I shared with her some of my personal experiences. Being born in the 50s, growing up, when I used to watch TV, I didn't see anybody on TV that looked like me until Diane Carroll was the very first major African-American actress to have a sitcom. And she was a single mom raising her son on her own. She was a professional woman. She was a nurse. Oh my God, it blew my mind. I never saw anybody like her on TV before. Not long after her, you started seeing African-American models. Naomi Campbell was one of them. beautiful women of color that were walking the runways in Paris. I never saw that growing up. When I was growing up, there were no dolls. There were no black dolls. All my dolls were white. What kind of message did that send to me? Next slide, please. Change comes with struggle. You skip, but that's okay. Change comes with struggle. Any change, even a change for the better, is always accompanied by discomfort. There is no way for us to get to lasting change if we don't get through the discomfort, if we don't push past our own personal feelings, our own biases, our own prejudices, to try to hear and understand what other people are saying. We're not being realistic if we're not honest enough to say, I have my biases. I have my prejudices. There are things that I think about people that may or may not be true, and I need to find out what's true. What's true? Because truth will stand by itself. It's all the lies, myths, and stereotypes that have to be propped up. Next slide, please. We in the mental health system are considered trauma informed. We've learned about the effects of trauma on people's lives. We've learned about the adverse childhood experiences. But there's also studies that have been done on populations of people who have survived horrific events. And it's intergenerational trauma. They have found out that when populations go through these events, that it affects the generations after them. This slide is 3 illustrations. Jane, whose great-great-grandparents survived the European wars, the trauma that was passed down to her years later, PTSD, alcoholism, sexual abuse, and emotional repression. Ashante, her great-great-grandparents survived slavery and racial violence in the South, and the trauma passed down through her generations: abandonment, domestic violence, low self-esteem, and PTSD. And then there's Asha. His family survived famines and oppression in British India. His great-grandparents did, and the trauma passed down through his generations was poverty consciousness, suffocating shame behind social rules, severe anxiety and depression. This is the reason why we can't just get over it. It's changed our DNA, our experiences that we have experienced as groups of people have changed our DNA. It affects our future generations. That's why we have to work individually on our own traumas and heal our traumas, and so that we don't pass it on to our next generations. The studies that were done about intergenerational trauma started first with families that had survived the Holodomor. It was mass starvation of Soviet Ukrainians from 1932 to 1933. And it was noticed that the survivors displayed social hostility and mistrust of people outside of their social group. So more investigation was done with Holocaust survivors, as well as indigenous peoples from the United States and Canada, as well as African Americans who survived slavery. So this is a common occurrence. It's not just African Americans, but any people who have survived horrific events has had generational trauma. And we all need to do what we can do to help people heal their own personal trauma so that they can interrupt that cycle and it doesn't move forward. Next slide. How do we do that? We don't do it through sympathy. People want to be sympathetic, but sympathy is, I'm sorry that you're in pain. You're not walking in my shoes. You're not coming into the moment with me. You're not feeling my pain. But when you empathize, you come alongside, you allow yourself to be vulnerable. You remember times in your life where a situation or circumstances had cut you to your core, and you knew how that felt. So when you see me in pain, you can honestly say, I feel your pain. I'm here for you. I want to walk with you through this experience. I want to support you in any way that I can. You may not be able to fix what's happened in the past. We're dealing with some very complex issues. Just when it comes to slavery alone, over 400 years of servitude with no compensation before or after, and all of the policies and generational uh, things that have been ingrained in our society that has kept my people, our generations, in a place of poverty year after year after year. So here we fast forward to this COVID-19 situation. And when the reports start coming out that African Americans were dying at so many higher numbers than other people, it pointed up the fact, things that we already knew, that the social determinants of health would be an indicator who would be able to survive the COVID-19 experience and who might die. I don't need you to fix me, but can you listen? Can you hear me? Can you allow me to share my pain and be healed from the pain of my past? Next slide. I have a dream. In 1963, Dr. Martin Luther King gave one of his most memorable speeches, the I Have a Dream speech. A few lines from his speech really resonated with me. The whole thing is quite powerful. But the things that I wanted to share with you today are, I have a dream that one day this nation will rise up and live out the true meaning of its creed. We hold these truths to be self-evident, that all men are created equal. I have a dream that my 4 little children will one day live in a nation where they will not be judged by the color of their skin, but by the content of their character. I am encouraged in this present moment that we find ourselves in, as an African American woman that have gone through all of the civil unrest and all of the protests and everything that's gone on before, to see the support of people all over the world, people standing up in England and France and the Philippines saying Black Lives Matter. People standing together in unity, calling for an end to the practices and the policies that impact people of color, not just African Americans, but Latinos, people from Asia and India. Sometimes these things have negative consequences and they're even deadly. There have been times when I have had to pull off the road when a police officer is pulling beside me. I look at my speedometer. Am I speeding? Did I do anything wrong? The anxiety that comes up, you have no idea. But I have a dream today. I don't just believe that change is coming. I believe that lasting, needed change is here. Next slide, please. In closing, I want to make my own tribute to all the heroes, not just to those who are designated as essential workers, but to everyone who has been courageous enough to do your part, to keep you and your loved ones safe and well. You who are watching and listening today, you are also heroes because you took the time to be a part of this very important discussion, although at times very uncomfortable conversation. I had to pull myself together. I'm sorry. There's a hero. If you look inside your heart, you don't have to be afraid of who you are. There's an answer. If you look inside your soul, and the sorrow that you know will disappear. And then a hero comes along with the strength to carry on, and you cast your fears aside, and you know you can survive. So when you feel like hope is gone, look inside you and be strong, and you'll finally see the truth that a hero lies in you. It's a hard road when you face the world alone. No one reaches out a hand for you to hold. You can find love if you search within yourself, and the emptiness you felt will disappear. And then a hero comes along with the strength to carry on, and you cast your fears aside, and you know you can survive. So when it feels like hope is gone, look inside you and be strong, and you'll finally see the truth that a hero lies in you. So with that, thank you for your time and your attention. You can go to the last slide. I just want to thank you in every language. I don't speak all these languages, but I just want us to be inclusive as possible. We know that there's people out there with all kind of different backgrounds, have been through some dark places, but you are a hero. And we will get through this. I believe that there's a rainbow on the other side of this storm. And I thank the staff at OCHN for bringing this production to life. It's our first time doing this, but I thank God for all the speakers that have gone before me, and I'm open to any questions that you may want to ask me at this time. Thank you all.
Hello. Oh, there's an echo. Can everyone hear me?
Yes, I can hear you.
Are there any questions? Thank you so much, Ms. Newman. That was very powerful and moving as well. Really appreciated all your words, your story, and as well as your singing.
Thank you.
Someone is saying that was beautiful and your voice is beautiful.
Thank you.
Another person is saying, thank you for being so open with us. Really appreciate your honesty and everything that you do every day. You inspire me and touch my heart.
Thank you. Thank you.
Okay. As you guys know, you can always text us any questions as well at 248-330-1175. I'm just going to check one last time. Cheryl is saying thank you for all your info and you inspired me. So a lot of positive messages of thanking you for being such an inspiration to us. And we definitely appreciate your continued work with OCHN.
Thank you.
So with that, I am going to actually, well, you guys could not hear me. I was announcing the drawing for the Panera gift card, and the lucky winner is Nikki Keller. Congratulations, Nikki. You will be receiving an e-gift card for Panera. So hope you enjoy that. And next, I'm going to hand it over to Trisha.
Hello, thank you again, Malkaya. You are always such an inspiration to all of us. Now it is my pleasure to introduce Dr. Eben Dotson to speak about influence of implicit bias on health outcomes. Dr. Dotson is an assistant professor in the Department of Health Management and Policy at the University of Michigan School of Public Health. So join me in welcoming Dr. Eben Dotson.
Thank you, Mr. Zumbo. I don't even know where to begin. Ms. Newman, you put us in a place, and I hope that I can authentically move us to the next step in this conversation, but I don't want to jump too fast because I'm still feeling what you just gave us. And so I can use this time to say thank you to the OCHN staff. From Ms. Lawson, Ms. Brewer, to Mrs. Zumbo, I can't wait to go to Q's place, the kitchen. We need to go there. I've also really enjoyed the time thus far, and I probably have more interpersonal questions for the speakers, and I want to present content and information. And so I really appreciate the slate of speakers that you have today. Some I agree with, some I disagree with, some I just want to push and prod so that we can have that authentic conversation around implicit bias, especially for mental health and thinking about mental health in communities of color. So I just appreciate that, and I appreciate everyone for what we've done thus far. I want to try and take us into the question around implicit bias and whether it's a real thing for us to use for action. And so the title here is the influence of implicit bias on health outcomes, but I want to take us somewhere. And so the style that I want to use today is a little bit fast. So as we do slides, I'll kind of go slide, next slide, and move a little bit quickly as we go through, because everything that I present, the content, there's so much. We could use the same slide deck and have probably 3 or 4 different conversations. So I want to pull just a little bit out of each one, and I'll try and highlight them on the slide, but all the information and reading slides, I know people say this often, don't put too much on there. This time I do. I want to have a lot of information for us to use moving forward and in our conversations that we have with our respective areas as well. So just a little bit about myself. I, as a professor at the School of Public Health, and I know there was a wonderful gentleman on earlier. I think he's the lieutenant governor who went to this wonderful school. University of Michigan, anyone ever heard of it? Please put in the chat if you have. Go Blue. Because I know there are some other individuals here from schools around the state as well. I won't mention them just yet. But if you are from Michigan, go Blue. I want to also say that next slide, please, that I run a research collaborative. And the research collaborative is called the Health Equity Leadership Pipeline Collaborative. And our research, our focus areas, it's leadership diversity enhancement, healthcare capacity building. And we really, really push this thing about health education programs. Because for us and for me and what I do, I think health equity is the answer to a lot of our issues. And so thinking about how do you manage health equity, the collaborative, as we lovingly call it, the collaborative is our place to have these provocative and interesting questions. And so we provide innovative, relevant, scholarly research on health professions and health education training methods. And so today, thinking about implicit bias is perfect for some of the things that we do. Next slide, please. The second thing that I want to say is I run a summer program, and the summer program is called the Summer Enrichment Program. And this summer program has been going on since 1986. And we've had 34 summer cohorts, and that's over 700 students who've been part of this program. And the goal is to change the face of healthcare leadership. And we want it to look like the patients. We want it to look like the community. We want it to look like the population we serve. And so that's another thing that's under our belt. And if you ever want to participate, I would love to have more partners. Next slide. And then the next slide. All right, so let's jump into this. I'm going to speed up. So right now, what's at stake when we think about implicit bias? There are a couple things to think about as we move on. One is we can't change what does not exist. And especially when there is no voice to object to what's happening. And I say that as a lead, and I'm not going to explain it too much, but bias itself is unidirectional. Bias in and of itself is not good or bad. But when we talk about unconscious bias, and I'm going to push from a couple presentations earlier, I want to argue that unconscious bias is bad. And I also want to separate unconscious and implicit bias. And I want to say implicit bias is worse. And if we talk about culture, and a couple of people talked about culture, I say culture complicates healthcare because of our values. And it's not the mission of your organization or the vision of your leadership, but it is around this other conversation of values. And I really hope that we get there, because this is one of those conversations that if we were all together in person, I know we're here virtually, but we need to look at each other and have this conversation. So next slide. So this is why I say they're different, unconscious and implicit. So unconscious, in some areas, you find the definition, it's a prejudice. And the prejudice is charged in and of itself, but it's based on stereotypes. And those stereotypes are held by individuals. And stereotypes are beliefs that people have of a group with some characteristics. And the stereotypes can go for gender, they can go for age. And here, a lot of those stereotypes play into how you think about an interaction. But the feeling here is that unconscious bias is something that you're unaware of. And I challenge that. I know that we're talking about implicit and unconscious also used, but I challenge that it's you're unaware of. Because if you're unaware of it, you're not responsible for it. Next slide. And so implicit bias. Remember I said that unconscious is bad, but implicit is worse. Implicit bias has a couple things in it. And those things include attitudes. And the other thing that implicit bias includes is a social outgroup. And if you think about an attitude is your evaluation of a concept. You think about an explicit attitude, you say, I really feel a certain way about something. And so the implicit part of implicit bias, or here you see the term implicit stereotype, is it's something that you think about, but the attitude that you use has some effect on a social outgroup. And so when you think implicit, and I very much so understand why we call it implicit bias is the action version of it. And so I want you all to think whether or not implicit and unconscious is something that you don't know. I think it's just something that your inner talks about, but they affect our understanding, our actions and decisions. And I don't know if it's in an unconscious manner, not from what I see and not from what I know with health outcomes. Somebody is culpable and somebody is responsible and somebody is accountable. Who are they? They are not nameless individuals. And remember, unconscious bias is individualized. It's an individual's perspective on this. So some individual has a bias and that individual is doing something with that bias to another group. And they're doing something with understanding, with an action and or decision. Okay? So next slide. I just want to give us two things here. One is I want to talk about disparities and inequalities. And just defining, I'm a professor, please forgive me. I always teach. I think teaching is awesome and great, and everybody here, we want to learn something. And so health disparities becomes a population-specific difference. You need to identify the who before you can call it a disparity, a health disparity. And then we sometimes throw around a couple terms, inequalities and inequities. And inequalities relate to a difference. And that difference, they're inequities. The difference is an inequity. And here in healthcare, the difference becomes health status or medical treatment. And the key is that the difference is unfair to certain groups. Remember that outgroup, it's different. And that the difference is actually avoidable. And I'm building my argument here, like it's avoidable and it's unfair to an outgroup. Next slide. And so here I want to just give you a little bit of context and giving you a hint of race. Because one, we're thinking about the quality of healthcare, and you look at two groups, white people and people of color. Let's go white and black. The difference in the quality of their healthcare is based off of three different things: clinical appropriateness, patient preference, the operation of the system, and then this other thing called discrimination that includes bias, stereotyping, and uncertainty. And I say those last two things, the operation of the system and the discrimination, that's what your health disparities are made of. Physicians, nurses, providers here, you're off the hook a little bit with the hat that you wear. The clinical appropriateness and need, we often believe that if you see symptoms, there's a protocol for you to use. There's no bias in that protocol. And for patients, you're kind of off the hook if you just use that hat, because when you go in, you say, here's my problem, here's my issue, you give it to the providers to solve. And so health disparities aren't your fault for that reason. But when we think about the operation of the healthcare system, and then we think about the biases and the stereotyping that we bring, you get back on the hook. And that's where disparities come in, because either you're operating the health system in some way that's advantageous, supportive, or enhancing, or you're doing it in the opposite way. And bias is that thing that continually creeps up. And I want to, next slide, please. I want to say that our implicit biases impact what we see and do. And in healthcare, it really matters. So really quickly here, I want to give everybody visuals. And you can put this in the chat, but I have a feeling of what you're going to say. So next slide. How might growing up in this community affect the health of the children? in that community? Are the children healthy? Are they served with the right nutrition? There's a sidewalk to play on. There's green space. There's lighting along the street. Kids in this neighborhood are what? Are they happy? Do they have health issues? What does your inner person say about this place? Next slide. Is this community better or worse for children? There are still sidewalks. There's still green space. Compared to the previous one, are these children a little worse off? Are they better off? Is it similar? Is the same to you? Yeah, we see that the lights are gone. We see that there's something that we think right now that we're doing, we're stereotyping. We're using our bias and our understanding to say something's different here. Next slide. What about the children that live in this neighborhood? The children in this neighborhood, do you think that they have health problems or issues? Do you think that they fear for their safety? What is that sound in your head going off and saying right now about this neighborhood? And when you see individuals in the neighborhood, are you afraid of them? Do you think that they're your neighbors? And these communities are Detroit Metro-based communities. And this is where our children live, and this is where we, as professionals and community members, we have to ask our bias and say, what are we going to do? So next slide. And I'd be remiss to say that I know that you felt something, and I know that you had a stereotype. I know that you had a bias, but I want to say that our biases are rooted in evidence. And let me build quickly a case around the evidence that health outcomes are related to biases, because biases hurt and they can kill. So next slide. And I want to use this terminology: population with a big P, population with a small p. And population with a big P is a large community. It's a set of individuals in a geographical area. It could be a state, it could be a nation, it could be a region. That's population health with a big P. Population health with a small p is individualized. It's a certain community. It's your community. It's what you see where you go to the store. Your population health is based on inequalities and then the inequities that happen. And so I'm highlighting a few of these, saying that race, income, and education, there's some really bad terms and ideas because they impact and influence us in certain ways. And bias and social determinants are thematic, but they rear their heads in race and in income and in education. And I want us all to know that, and I want us all to see how the evidence says that health outcomes are related to these very things that are based on stereotypes and attitudes, and they play out in very, very significant ways. Next slide. So race impacts cancer deaths. White, Black, Hispanic. Who has more? Think about heart disease. Think about breast cancer. Stroke may be on par, but race impacts cancer deaths. Next slide, please. This is a really interesting one, is that race impacts healthcare costs. So you discharge someone, Medicare patient, 1 month, 2 months, 6 months after discharge, what's the cost of caring for that patient? This is for the providers, you don't want them to come back. This is readmissions. These are complications. But the black line at the top, that's Black. Hispanic is red. Asian and white, the white is the hyphenated, the dotted. Why? Why would there be follow-up and readmission and residual outcomes that are different that cost Medicare money in a different way, but race impacts healthcare costs. Next slide. Income impacts health outcomes as well. What do you see here? For high blood pressure, for asthma or diabetes, you see the trend. The trend says the more money you make, the less of an impact health is on your everyday life. Next slide, please. And education as well impacts health outcomes. What you see is if you're self-reporting, you say you have fair, you're poor health, you have limitations in your daily activities, the more degrees you have or the higher your education, the fewer of those things matter. And it's just an interesting way to say, what does the evidence tell us about bias? Because there's some reason why these issues plague us in certain ways: race, income, and education. Next slide. And I'll just say that that relationship exists between race, income, and education altogether. So if you look at for race, what's the rate of high school dropouts? Or what's the rate of those who are below the poverty line? And you can see that that includes income, that includes education. And there are some races and ethnicities that stick out versus others. Next slide. And then this is kind of where bias impacts us in a wow way when you look at this next one. Next slide, please. Because race impacts life expectancy. Is it not advancing?
Sorry, just a moment. A couple of technical difficulties.
Well, what it'll show you all is that life expectancy is lowest for Black men, and life expectancy is highest for white women. And when I say that race impacts life expectancy, well, there's something that we do around stereotyping race. There's something that we do when we act based on the attitudes that we have around race. And so giving you this is as a precursor to saying, what are we going to do about this? Okay, next slide. And this is just giving you a definition somewhat of race and saying that it's a social construct and it has physical reach. And Kamara Jones, she's a really good author if you ever get a chance to read her, but you see her picture, and her picture here, she said, in the United States, I'm Black. In Brazil, I'm labeled white. In South Africa, I would be labeled colored. But her genetic makeup is the same. It's not changing. And here's an idea of what race means and how it's a social construct. You hear my kids in the background. That's funny. The next slide, please. And so I want to give two things around where does this matter? Where does this impact us? We're talking about implicit bias. How is it acting upon us? So we see here this idea of a person and they need help, and someone's helping this individual. They're in the water for some reason. They're saving them from drowning or what have you. There's a specific type of treatment or life-saving procedures that you give to that individual. You could care less about what's happening, but this is how specific you need to get in order to help this person. That's downstream. Upstream, we come to find out that that individual was part of some type of earthquake where the bridge fell down and they inadvertently got put into the water. And so the upstream issue of the bridge collapse and some earthquake ended up creating the downstream problem where we're specific in caring for that individual. And so upstream and downstream issues, next slide, please. Kind of in healthcare, this is where the social determinants of health matter. And it's a classic training where the upstream determinants that include income, education, and race and bias play in impact us downstream, what type of medical care we get, the behaviors and the lifestyle choices that we have, what our environment does upon us, and that impacts our health outcomes. Next slide, please. And when you think about where our health is, individual, you, me, where our health issues, where the sensitivity comes from, it's not necessarily medical care, although it is. Some of it's our genetics, some of it's our circumstance and environment, but by and large, there are these behavioral patterns that act upon us. And these behavioral patterns that act upon us give us better outcomes, worse outcomes. Next slide, please. We'll move past that one and go to the next one. And I'm going to bring up this term, allostatic load. Clinicians, you know this. The rest of us, I didn't know about this, but allostatic load is that physiological, it's that response. It's the physical space of measuring cumulative burden that's exacted on someone's body. And if you think about what the source of those stressors are to get your allostatic load, it could be economic insecurity, job insecurity, racism, sexism, unsafe neighborhoods, crisis situations that impact us differently. What does that tell us? That tells us that your cumulative physiological burden does something to your body. And that burden comes from something that happens to you every day. Next slide, please. And when you're exposed to everyday life, the built environment plays a big role in what your health is and what your health outcomes are. Next slide, please. And so the connection between stress and health, I won't really talk about the term ghetto miasma, but it's this idea that the neighborhood you live in gives you poor health. I showed you the picture of Kamara Jones, and she said, even though I'm Black, white, and colored in different countries, whatever that placement is, that's the health status that I'll eventually have. So I'll eventually have the average health status of a Black person in the United States if I live there, of a colored person in South Africa if I live there. And ghetto miasma is kind of one of those things that talks about that. It's just feeling that people who live in disadvantaged neighborhoods have more heart attacks. If you live in neighborhoods with abandoned buildings, there is a higher rate of early death. If you have a higher allostatic load, your mortality and your cognitive and physical function decline faster. Oh my goodness, this is the wait a minute. You're telling me that just because I'm in an environment and just because I am something that I'm going to die sooner. My life expectancy is lower. My health outcomes are poor. And I'm saying yes. Answer your question, yes. Next slide, please. And I'm also telling you that the reason that is happening to you is because microaggressions mediate health. You can't see this, but microaggressions mediate health. And microaggressions are brief. They're commonplace. They communicate hostility. They have derogatory impact. They have negative racial slights and insults. Where are we actually seeing this kind of stuff right now? This tweet is in San Francisco, the Board of Supervisors. There's an individual, Mr. Walton, and he just said, I introduced the Karen Act. And the Karen Act is caution against racially exploitive non-emergencies. It's those individuals that call the police on their neighbors of color. And if you're on social media, you can't get past this. But microaggressions impact us in not just a funny, interesting, oh my gosh, I can't believe she did that way, but in a very specific physiological way that impacts our health outcomes. Providers, this is what you're seeing when people present themselves and you're trying to figure out what it is. It is implicit bias acting physiologically and making our individuals sicker. And so let me close with, I think we're ready. Let me close with this. So the next slide, please. So if you think about bias, you think about health equity, and you think about Michigan, there was a really wonderful Go Blue person, and our governor has been pushing and touting something that I think is really important. And they've been pushing, how do we save ourselves and reduce the impact and reduce the problems that are associated with COVID-19? Next slide, please. And I want to start by showing you this. So you're starting to see, hopefully the GIF is working, but you're seeing this is day by day. And day by day, starting in February, these are cumulative cases and deaths per capita by state. So the red dots are different states. And the size of the dot says how large your state and the population is. So New York has a large one, California has a large one, Michigan somewhere in the middle. But this is the cumulative cases and deaths per capita, depending on if you're on the y-axis or the x-axis. But this is every day. This is May or April 29th or April 11th, April 13th. This is what's happening every day. And you can see this trend. There are more cumulative deaths and there are more cumulative cases. And Michigan is right there in the middle somewhere. And it's how do we slow the curve? Everyone is doing something by each state. Some states are worse off, some states are better off. But why? Why are we seeing more cases and why are we seeing more deaths? And our speakers today have already told us deaths are related to race and ethnicity and culture. It's the way that we interact. It's the bias that we have. It's the decisions that we're making. Like these decisions are impacting us in a very, very negative way if you're a person of color. You're 2, 3, 4 times more likely for cumulative deaths. You're 2, 3, 4 times more likely to get a case of COVID-19 just because what I would argue is bias exists. Next slide. And last week when the governor and lieutenant governor said, we need to realize that the way in which we are creating our daily lifestyle has an impact on other people. And this bias is going to be interjected at any point when someone has to make a choice or decision. And couple that with, we're going to make masks a requirement or seemingly have some type of penalty. It's the incentive. And we think of implicit bias, we're defining it just like I defined it today. It's unconscious, it's negative, it's physical attributes. I still argue with the unconscious part about it. Because these are decision makers and decision makers need to have good information. And if there are unconscious things that they're not responsible for, then the outcome of what's happening, no one can fix, no one can solve. And so I want to think about this context of last week when the governor, lieutenant governor, and others said, we need to require masks. People just put them on, right? This is the conversation, just put them on. Now I want to say, what's going to happen when you think about bias, when people start to put these on and you don't have the conversation that we have today? You don't have at least an alert to your unconscious bias. Next slide, please. Because I think that the no mask, no service, no exception, that's the right thing to do. But you add bias. And what does bias say? Bias says that if you're black or brown and you have on a mask, somebody's going to make a decision, somebody's going to have an attitude, and somebody's going to stereotype you in a way, right? This person has on a hoodie and a mask. And you think about which neighborhood are they walking in? And depending on the neighborhood that they walk in, what's going to happen? Mr. Anderson, Pastor Anderson, actually, is a faith-based individual. And you kind of think of what's going to happen.
This is when... on. I'm about to go.
Oh, somebody on there? Oh, I'll go ahead and finish. Pastor Anderson is an individual, but what do we do? Now that we're requiring everything and we're saying we're starting with healthcare workers, we want healthcare workers to have some implicit bias training, great. What about everyone else? And if we don't have things like the Karen Act, if we don't have other disincentives for people's stereotypes, behaviors, and attitudes, then we just seemingly assume that it's unconscious and we give them the benefit of a doubt. This individual may not have that chance for the benefit of a doubt. Next slide. And so I close with us thinking about that and thinking about what's our call to action. And what's our call to action here is I believe that we need to frame implicit bias and we need to frame it in health outcome language. You don't say that they're implicit bias, you say implicit biases kill people. Let's change. Implicit biases increase health disparities. But don't just use implicit bias without coupling it with something. And I also think that we want to expand the training requirements. It's not just healthcare workers, it's the healthcare leaders. They're the ones making decisions. It's businesses where we know the issues happen because we've experienced them. And again, consider a Karen rule, because if you couple a Karen rule with the requirement in the business, someone's going to think twice about acting on it. And then I also want to say we have to think about health equity and framing things in health equity and a health equity management model to say we're in this together. And we truly do understand that we have to define health equity. We have to define these issues in context of people. And then our initiatives need to have some sense of partnership and connection to others. And that's the kind of work and that's the kind of research that I do. And talking to you all today, I think hopefully we can get to that place, and hopefully we can get there quickly, because if not, it could double back to that slide that showed the cases and the deaths, because that's going to keep going until we address, which the state of Michigan, we smartly said implicit bias is part of it, and it is a big part of it. And if you can manage and or handle implicit bias, then you're able to address some of these other things. Next slide, please. So I want to say to everyone, thank you. I know that you stayed in there, the 70, 80 people here on the line. I know that we have lots more to do, but I'm open for questions now. I know the time is there and we can have more question and conversation later. And please, I'll try to make sure that I have my contact information there so that we can have a more in-depth conversation. And I hope that OCHN brings all of us back to have more conversation around this. Thank you.
Thank you, Eben, so much. And for my providers on the phone, I am talking with Dr. Dotson to have him come back again. So you will still be hearing more from me, Eben. So just wanted to take some questions right now. You can use the raise your hand feature. You can use the chat. You can also text your questions to 248-330-1175. Eben, I think you can see the chat, but just a lot of thanking you for the presentation and very informative. I love that you brought that up about the masks, because I know myself and people I know of who are of color have had that conversation since March.
Yes.
And talking about masks. So I don't think I see any hands up. A lot coming through the chat of just thanking you.
Yes, well, how awesome are you and the team at OCHN? I know this was planned months ago. You're smarter than the governor and you're smarter than the healthcare individuals in their state to say, we're going to have this implicit bias conversation way back when. And it just happened to dovetail in the right day and right time. So kudos to you all to have this conversation right now, because you're leading the pack.
Well, thank you. We try. Michelle, I'm going to call on you first with your hand raised.
Thank you, good sir, for everything that you've shared today. I am wondering if U of M is thinking about or moving toward having implicit bias courses as a part of curriculum that is mandatory.
So I'd love for you to call, to email, to tell everyone that we need to have that. So yes, we do have curriculum. We have curriculum for staff and faculty and leaders that you can go and do online at the School of Public Health, which everyone is watching us because we're the group that is informing the public health informed semester. We're the group that's informing the state on what to do and how to look at things. So they're really looking at us to see what we do with our own students and our own faculty and our own staff. And this conversation, when we define informed, we're including this part of the training. So it's there. I haven't seen what the actual content is, but there are several of us who are involved in implicit unconscious bias. We also call it anti-racism perspective. So we are looking at it in that way. And so hopefully we'll get that. Training wise for faculty, we're back. This is like my second week of really feeling as if you got to get ready for the semester. You know you're going to have it. It can be in person. So we're getting there. And implicit bias is a conversation because we have yet to really say what we expect for our students walking in. We're starting to put in screening checkpoints and other things, but the mass conversation hasn't truly come up, but this implicit bias conversation has. The unconscious bias conversation definitely has. But I don't know, and nothing officially has been said here, but I am within the school and within my department and the students that I'm connected with. Yes, we are having this conversation, and some of the trainings, even student organizations are starting to put together their training. So we're doing it from a grassroots perspective, and we hope that the leadership jumps in as well and says we need to require it, because I heard you say require, and I'm hoping that that is true.
Great, thank you. We have another comment in the chat. Please share your perspective on the momentum we are experiencing with the conversations around race.
Yes, and so race, what I didn't give you all is sort of that complication of race and a bunch of health outcomes. I gave you one or two, and race right now has a social media spin to it, but race has the evidence, and the evidence exists. And so when you think about what we're experiencing around race and you see the reactions, the commitment, the letters, the support, I stand with, those are really good feeders into implicit bias training. But when it comes to acting and action, what I'll say is the way action looks for someone to say we are addressing race, someone said it earlier, your board seats, your board dynamics need to change if you're in healthcare. Your leadership should optically look differently. And I think in one of the early slides that says, like, if you aren't having the conversation, it's probably because someone of that race is not in the room. And when someone of that race is in the room, or someone of that positionality, as we like to call it, is in the room, you often get stronger conversation around it. And so I get the social reaction, and we need that. The professional reaction and the leadership reaction hasn't yet shown itself to be a lasting thing. And I think there are many of us who are working, I don't say this behind the scenes because this is our scene and we do this work, but the behind the scenes change, you're starting to see some policy work, but policy is in a political year. It's going to be kind of tough. But you're looking at people trying to brush off their policy that they've had in the drawer for the past 10, 20, 30 years because we know that race impacts things in this way. And so you're now starting to see that coming out and people trying to reinvigorate or get the motivation back to make that happen. So I hope the momentum still moves forward. But our version is health equity management. You need to manage this. You need to manage this with partners, and you need to have a sound perspective, not just one organization, but multiple organizations define health equity in the same way, define implicit bias in the same way, because then your solutions are similar as well.
Great, thank you. We have one more question from Dr. Rosen, and then I'm going to turn it back over to Nada.
You were talking about the relationship between poverty and health outcomes.
Mm-hmm.
I'm wondering what you might say about how we fund healthcare, or the fact that millions of people have no healthcare. So yesterday I'm reading in the paper that 22 million people have lost their health insurance in the last couple of months. And even when we try to create avenues for people to get help, the mechanisms we put in place. So, for example, creating unequal systems, like we have Medicaid, which is underfunded, and private insurance is probably overfunded. But so yeah, well, you have Medicaid, so you're going to get great care. Except we know that the dollars that go to Medicaid are inadequate.
Dr. Rosen, you and I are kindred spirits. The response that I can say to you is, when you think about the operation of the health system, it is designed to do exactly what it is doing. That is a sobering statement, and I hate to say it here, but our health system is designed to be advantageous for certain groups and disadvantageous for others to seek access to care and to get quality care. And if we were in class with these wonderful students that are coming this fall, I will tell them that waste in the system is in the hundreds of millions of dollars every single year. And that we could, if we were thinking strategically, have a different way of delivering care and actually care for more people. And so I'm with you on that one. Medicaid, Medicare, there are some states that have adopted Medicaid expansion when you think about policies, but the way in which we use resources and the way that we actually identify problems or count people for problems and issues, it's this public system, but it's this private way of doing business. And so because there are so many organizations doing things differently, albeit under the same regulations, but every healthcare system and organization has a different population set, has a different panel, has a different grouping in the way they interact with one patient. So all these things impact us because we can't find how to maximize the money because so many different people are using it at one time. And the impact is negative on populations of colors, negative on low income individuals. It is negative on those communities that don't have direct access to care right where they are. And so it's there. And so hearing what you're saying, yes. And then how do we handle it? How do we solve the problem? We need to train more managerial individuals. We need to train more policy people that have an expertise and have a background in understanding healthcare and how that infrastructure works, because we need a new system. Not saying the one we have is bad, but we need a new system because it's designed to do what it's doing. And if we want to change it, we have to change that system.
But the irony is that if we were able to have equitable health care, we would actually save money.
Yes, I know. Yes.
We wouldn't bankrupt the country. We would rescue the country.
Yes, yes. And there are some states and some programs that will show you a return on investment year after year. There are some really smart companies out there. One Medical is one, to give an example. I guess I'm not plugging too many things, but One Medical is a sort of concierge private way, and they're using general funds and they're able to make money. And they have physicians, they have networks, they have all this. You can see this around the country. We know how to do it, but we're not necessarily doing it in a health equity management way, bringing all the partners together.
Great. Thank you again so much, Dr. Dotson. Nada, I'm going to turn it over to you.
Hello, can everyone hear me?
Yes, we can hear you.
Okay, awesome. Wonderful. That was really, really wonderful. And I'm excited. Trisha said that she will be bringing him back. So I'm excited to learn more. And next, we wanted to welcome our very own Julian Turtzag. And he is a wonderful, wonderful gentleman that works at OCHN. He is the facilities attendant and member of the Dreams Clubhouse, and he enjoys weekends, times with friends and family, and he loves to travel. And he will be sharing his personal story. So welcome, Julian.
Hi, guys. Can everyone hear me?
Yes, we can hear you.
Okay, I hope everyone's just doing dandy on this fine Tuesday. I hope everyone's having a good day. My name's Julian Turtzag. I work here at OCHN. I've been working on the facilities team for about 6 years now. I extremely love it. I'm super fortunate to have good people we work together with, and it's been the most amazing time of my life. Best job ever, and it never fails to succeed my expectations on before I even started. Let me just dive in. Before I had my job here, I was about 6 years ago. I did a full 360. I turned my life around, and knowing what I know now, there's a couple things I would have told myself back then, but I've actually learned now that all the things we go through, the ups and downs in life, if it's not making us happy or it didn't help us, it's just a lesson. So I learned a lot of lessons, and I just wanted to say thank you to everybody for making work such a good such a good time for me. Before I got the job interview that I took to get my position here, I was on the phone with the Social Security agency in Michigan because I wasn't planning on working. I was planning on getting Social Security benefits. So I was on the phone and, I was going to get benefits, Social Security benefits, because I didn't have a job and, I was really down on my luck. I was struggling. I'm still bipolar, and that's been a journey. Before I got my job and my interview, I got the call saying to come in for an interview the day after I almost applied for Social Security. So I got the interview, and then it's history ever since. Lots changed. I owe a big thank you to Clubhouse, Dreams Unlimited. If you're not familiar with Clubhouse, it's kind of like a pilot program to help people get acclimated and have somewhere to go during the day and help out. When I was going to Clubhouse, that's the only place I could go. I was on house arrest and, I wasn't doing anything, and that was the only place I could go. So they knew I liked to work. They knew I had some jobs after I got my legal situation situated. I had some part-time jobs. Some of the staff members at Clubhouse found out I stopped working, and they said, OCHN might be interested. And so I've been working ever since. They told me I was going to speak today, so I just had a couple notes I just wanted to share. I know it's diversity. And then, when I heard it was diversity, I was like, what is diversity? So I looked it up. Diversity means the state of being diverse, aka variety or a range of things that are different. So my whole life, I've been biracial. My mom's Black, my dad's Armenian. And, my whole life, I never experienced racism, but, with everything that's been going on, I had a light go off in my head that says, maybe some of those things I'm thinking about were a little derogative or racist. But, I tell people, I'm the type of guy to give you the shirt off my back. I say, don't help me, go help someone else. I don't need your help, but some people, when you walk outside, they see you as, your skin color. And I never saw color growing up or anything. But I'm biracial. So, there's been a lot of times, even to this day, sometimes I'm too white for Black people or I'm too Black for white people. So it's really different. So you try to get in where you fit in. I'm lucky enough to have a really good place to work that I find that makes me happy, and the people I work with don't judge or discriminate against me. I don't think racism has a place in today's world or society. I think the further we get away from how things were, way back when things were worse for African Americans and all other races, just makes me think, the further we can go, but it's not going to happen overnight if we just decide to leave it to the future. I think the groundwork needs to start. We work in the healthcare business. I think the foundation of a lot of the laws and policies in our country, it is a racist system. It was born on racism. I think it's systemic racism. I think there's a big political, social, economic inequality. That's also to touch back on, I heard one of the doctors say there's a system health disparity. I agree with that. There very much is. I think we work in a time where we call the healthcare system healthcare, but really it's a, you know, all of us, all of our people are sick and tired of being sick and tired. And we call it a healthcare system, but really it's a sick and tired system. I think there's more policies to be reviewed. I think, just to start in your own community, ask yourself what you want to see different. Not to just jump all the way up and say, we need a new president, but just to start by voicing your opinion, what you want to do differently. I think if we value one person's health, that means we value the whole healthcare system. So I think we need to break it down to how can we really help these people get healthy. And through all I've been through, I still have to remind myself to be healthy. I still have to be healthy, and that's something I strive for. So I think there can be a better foundation, and it starts with the layout. And I think there's a lot of good people that are here before us that have really just carried the torch. So we have to remember them, the good people that were here before us, and that have only started the fight against systemic racism, a better healthcare network and system. So I'll finish up with a couple of things. I learned in my life with my career at OCHN and, the times before I started work, it makes me happy to work. I really wanted to work, and I found out that, I liked work, so I'm lucky enough to enjoy what I do. It doesn't always make you better to have more things than someone else. For a long time, I thought if I had more things, more nice things, it would make me better. But really, what I learned is that the less you have is almost better. Honestly, I don't know. Sometimes the less you have is better, because as long as you have what you need to have to do what you need to do, that's more than enough. You can have it, and as long as you have what you need to do to be able to do it, you have everything. So we have this time now, this moment. It shouldn't take all this stuff for us to really, break down things and say, this needs to be different. It hurts to know that things have a place and time that hurt. I feel like we all feel the same pain, when we hear and see things that are happening in today's society. So yeah, I just wanted to talk a little bit about courage and strength, and that's kind of what I was getting at. It takes courage, it takes strength. And sometimes I said diversity means the state of being diverse, aka variety, a range of things that are different. Sometimes people dislike what we don't understand or what they don't understand. So that doesn't make it wrong. It just means they need to learn to not look at things that are different as bad, but an opportunity to learn. That's kind of like it took a lot of courage and strength to be able to wake up every day and come to work. Because before work, I wasn't the best. I wasn't well off, learned a lot of lessons, like I said. But I think as we move forward, and as I've grown and, been working, and the time that I've spent at the job here, I've learned to love what makes me different, to love the lessons I learned before I started working, to just have hope and faith and love, and it makes you who you are. I recently learned something said, the moment you decide what you want, in that moment, the time you decide what you want and the time in between where you get what you want is the moment. That is the moment. That's the moment where you decide what you want in that moment, and then the time in between you get what you want is the moment. So we have to live for the moment and understand that the moment's here for us, to be courageous and strong through hard times. World's in a sad place right now, but it never hurts to stay strong and courageous, to not forget the things that have made you you and what got you this far. I never forgot what was before me or everything that I did to get to this point. So that's all I have to say. With one more thing, I'm just going to leave everyone with a nice quote. This quote is from my favorite girl, Maya Angelou. So if you just listen, this is the last thing I have to say. It says, "We delight in the beauty of the butterfly, but rarely admit the changes it has gone through to achieve that beauty. I've learned that whenever I decide something with an open heart, I usually make the right decision. You can only become truly accomplished at something you love. If you don't like something, change it." Maya Angelou. Thank you, everyone.
Thank you. Thank you. That was so wonderful. We have so many messages. Everyone appreciating you. Everyone saying you did a wonderful job. Someone sending you a virtual hug.
Oh, nice. A virtual hug.
A virtual hug. And someone said a sick and tired system. That was actually pretty good. I thought that was pretty good as well. Does anyone have any questions? Kenyatta is saying that was her mother's favorite quote as well. So,
oh wow, what up, Ken?
Does anyone have any questions for Julian? Everyone's just saying thank you for sharing. You are so insightful. That was really good, Julian. I'm very impressed.
Thank you. I do my best.
And on behalf of myself and OCHN, we thank you for everything that you do. And you are always so positive and making sure that everyone's doing well. And you always come and chat with everyone with your positivity, uplifting everyone. So we really appreciate everything that you do. And we enjoy having you at OCHN.
Thank you, guys.
I think there are no questions. So I think with that, I can go ahead and do the closing remarks. Thank you so much again, Julian. Really appreciate it.
Thank you, everyone. Have a great day.
Have a great day. See you soon.
Okay. Bye, guys.
Bye. And to everyone else, thank you so much. We do apologize that it went a little over time, but thank you for joining us for the OCHN Minority Mental Health, Mental Awareness Month virtual event. Thank you to our amazing speakers today. We are grateful for the valuable information shared about minority mental health, racial disparity in healthcare, and the implicit bias in health outcomes. We are especially grateful to the OCHN Minority Mental Health Awareness Month Forum Planning Team, which is listed in the slide. We appreciate all your hard work for this event. The event has been recorded and will be posted on the OCHN website for you guys to view later or share with anyone as well. Before we close the event, we'll do another quick drawing actually. So I hope you guys are excited. And this time it is a Starbucks gift card, and the lucky winner is Clarice Harris. I apologize if I mispronounced your first name. So Clarice Harris, you will be getting a e-gift card for Starbucks. Thank you so much for attending our virtual event. Have a great day, everyone. Bye.